videos.
Yeah, doctor.
Okay.
Yeah.
Hello, good evening. hello, Dr. Parimala and
Hi, ma'am.
Dr.
Hi, ma'am. Good evening.
How are you?
Good, ma'am. How are you?
Good. And is Dr. Vinita also online?
Yes, ma'am, I'm here.
Yeah, good evening, Vinita.
Good evening, ma'am.
Yeah, thank you. Thanks to all of you for making this happen, making this possible, rather. In fact, I was just communicating with Dr. PM Chandrasekhar. He's just had a stent on Wednesday after he uploaded the talk on acute MI.
What was it?
Oh my God.
Yeah, but he said he's recovering. So I said, thank the Lord. Really, God's grace. He just uploaded and he went for a stent. He just messaged me a minute ago.
Oh my God.
It's so. I
So
think
madam is also will not be joining today, ma'am.
she is. Madam.
Dr. Iris, she's
Actually,
coming.
yes, all of them. They have uploaded their talks. In fact, everybody has uploaded their talks. And it's surprising.
she
I
uploaded.
gave her acute coronary syndromes and
Correct. That's the presentation. Madam, even I am having actually bronchospasm.
oh my goodness, I can't believe this. I hope you're okay now.
Yeah, I'm taking medications, but this is seasonal for me.
Oh, okay. I mean, like, my goodness, I cannot believe this. How I know the right people are speaking also for
Coincidence.
topics coincidentally. But Dr. Elan, how has the show gone on from morning?
From
All
morning
well?
it has been good, ma'am. It's been and it has received a good response also.
Very good.
Almost 1,500 plus registrations.
In spite of it being a working day, the whole day.
Yeah, 1,500, ma'am. Not 500, 1,500.
Super. Very nice. I hope people log in for this topic because it is so
No,
essential.
many were telling they are going to log in. That hall A already has people, ma'am. I'm seeing both the sides.
Excellent.
Actually, I've logged into the audience side also.
Okay.
Dr. Kadambi is also sitting there.
Oh, how nice. So we have veterans and seniors. Absolute. Has Dr. Jayachandran also logged in?
No,
Not yet, I think.
Not yet. Okay. Has Dr. PMC logged in?
no, ma'am. No, only 5 of us are here. You, Dr.
Yeah.
Parimla, Dr. Vinita, Jyoti, and myself.
Okay. Anyway, sequentially the videos will be played, right?
Yes.
So,
Jyoti, adu ಮಾಡ್ತಿರಲ್ಲ? Say yes or no, ma, Jyoti.
Yes, doctor. Yes, doctor. Sorry.
okay. So I'll just introduce the topic and the speaker in half a minute and then let her start the video.
Okay, doctor.
Okay. Jyoti, you have the sequence, right? You have the program and the sequence.
Yes, doctor. We have.
Okay, the only
ಒಂದ್ಸಲ
one.
ಹೇಳ್ಬಿಡ್ತೀರಾ ಟೈಮ್ ಇದೆ ಜ್ಯೋತಿ ಹೇಳ್ಬಿಡ್ತೀರಾ ಏನ್ ಸೀಕ್ವೆನ್ಸ್ ಅಲ್ಲಿ ಇದೆ
Okay.
It's a systematic emergencies in a ophthalmic practice. First come Dr. Anup and Dr. Vinita, Dr. Iris Rajiva, Dr. Jayachandran VV, Dr. Pramila, Dr. PM
Parimala.
Chandrasekhara.
Dr.
Sorry,
Parimala.
Yeah, sorry. Dr. Parimala, Dr. PM Chandrasekhara, and last one is Dr. Suman Shri.
Okay. So you want me to give the topic and one line on the speaker, right?
Yes.
Fine.
Okay.
So is it gone on time, Dr. Elan?
Yes, ma'am. Yeah. Another, I think 6 minutes is there, no, ma'am?
Okay, yeah, 6 minutes.
6 minutes before we start. 6 minutes because some people might join in.
Yeah. Sure.
ಜ್ಯೋತಿ ಅವರೇ,
ಹಾ ಡಾಕ್ಟರ್.
ಇದು ಹಾಲ್ ಅಲ್ಲಿ ಇನ್ನೂ ಅದೇ ಸ್ಲೈಡ್ ಇದೆ. ಸೆಷನ್ ಫಿನಿಶ್ಡ್, ರೆಕಾರ್ಡಿಂಗ್ ವಿಲ್ ಬಿ ಅವೈಲಬಲ್ ಸೂನ್. ನೆಕ್ಸ್ಟ್ ಇದು ಅಂತ ಹೇಳ್ತೀರಾ?
ಯಾವ ಯಾವ ಹಾಲು ಡಾಕ್ಟರ್?
ಹಾಲ್ ಎ, ಕ್ವಿಜ್ ನಡೆದಿದ್ದ ಹಾಲ್ ಅಲ್ಲಿ.
ಓಕೆ, ಏನ್ ಸ್ಲೈಡ್ ಇದೆಯಾ ಇನ್ನ?
ಅದು ನೋಡಿ, ಎರರ್ ಅಂತ ಬರ್ತಾ ಇದೆ.
ಇಲ್ವಲ್ಲ ಡಾಕ್ಟರ್. ಚೆಕ್ ಮಾಡ್ತೀನಿ ಒಂದು ನಿಮಿಷ.
ಓಕೆ, ಚೆಕ್ ಮಾಡಿ. ಹಲೋ ಡಾಕ್ಟರ್ ಹೇಮಾ, ಹೇಳಿ.
Dr. Ilan, it will work from 6 p.m. it seems.
I didn't hear, ma. Sorry.
6 p.m. ಇಂದ ವರ್ಕ್ ಆಗತ್ತಂತೆ ಡಾಕ್ಟರ್.
Okay, okay, okay.
Doctor will start in 3 minutes.
Okay, Ms. Jyoti.
Doctor, shall we start? It's all
Yes.
six. Yeah. You can start, doctor.
Good evening, everyone. We just finished the postgraduate and the beginner session. We had the free papers, almost 22 sessions in the morning, and then we start with the actual program of COSCON for practitioners. The one thing that ophthalmologists dread is a systemic complication, be it even poking a needle inside a vein. I think we would have did it more than 20, 25 years back. And when a patient collapses in the OPD, be it because of vasovagal or some other serious concern, we are taken aback for a minute. Here we have a team of experienced anesthetists. This entire program has been conceptualized by Dr. Suman and Dr. Suman, Dr. PM Chandrasekhar, Dr. Iris Rajiva, Dr. Parimala, Dr. Jyoti, Dr. Vinita, and Dr. Jayachandran will be teaching us about the common systemic problems that we face when we are encountering eye patients in the OPD. Over to Dr. Suman. She doesn't need any introduction. For those of us in the eye hospital side, she's very active on the NABH circuit, and she was my ex-boss when I started my career. My first practice, she was the anesthetist for the first surgery I did in private practice. Over to you, madam.
Very good evening. Hari Om, like the scriptures say, Prajvalito Jnanamaya Pradipaha. May the light of knowledge enlighten all of us. Well, when Dr. Elan invited me and said, which topic? I said, why not something which is of significance to all of us, like systemic complications in an ophthalmic practice. Basically, this would enlighten us as how to have a high suspicion index and recognize pre-arrest scenarios before we get into a code blue situation. And of course, how to manage a code blue. It gives me a great privilege and honor to welcome our chairperson, Dr. PM Chandrasekhara, who is a consultant cardiac anesthetist with 50 years of experience, golden years, great veteran amidst us, and a doyen in the field of anesthesia. He is with the Retina Institute of Karnataka. And the co-chairperson is Dr. Jayachandran himself, a senior consultant from Shankar Netralaya, Chennai. He is the chief architect of the Association of Indian Ophthalmic Anesthesiologists. And he's also the present president of the World Congress of Ophthalmic Anesthesia. Once again, welcome both the chair and the co-chair. Now, our first speaker for today is Dr. Anup. He is having 15 years of experience in the field of anesthesiology. Presently, he's a senior consultant at Netradama Super Speciality Eye Hospital. So the first talk by him would be on life-threatening arrhythmias. Let's listen to him.
Good evening, everyone. A warm greeting from Netradama Super Speciality Eye Hospital, Bangalore. At the outset, I would like to thank the organizers of COSCON 2021 for giving me this opportunity. My topic is life-threatening arrhythmias. An abnormality of cardiac rhythm is called as a cardiac arrhythmia. An arrhythmia can present as sudden death, syncope, heart failure, dizziness, palpitation, or can present without any symptoms also. In an ophthalmological setup, where we can get an abnormal rhythm is while getting an evaluated for surgery, we can come to know, or during surgery when a patient is connected to monitors, or during a code blue call whenever the patient collapses, you can present with the abnormal rhythm. Classification of arrhythmia is based on the heart rate, basically. So heart rate less than 60 beats per minute is called as bradycardia. It can be sinus bradycardia or a heart block. Arrhythmia, when heart rate more than 100 beats per minute is termed as tachycardia, and which can further classified depending on the QRS duration into narrow complex or a broad complex. Narrow complex tachycardia can be sinus tachycardia or a supraventricular tachycardia, which are regular rhythms, and atrial fibrillation or atrial flutter, which are irregular rhythms. Broad complex tachycardia can be ventricular tachycardia, ventricular fibrillation. Bradycardia is defined as a pulse rate less than 60 beats per minute. Bradycardia can present itself in several different cardiac rhythms, which include sinus bradycardia and varying degree of atrioventricular heart blocks. This is a graph of sinus bradycardia. This is a third degree AV block. The bradycardia algorithm always assess the appropriateness of clinical condition whenever the heart rate is less than 50 beats per minute, and continue to identify and treat the underlying cause. At the same time, maintain a patent airway, assist breathing as and when necessary, give oxygen, and monitor for blood pressure and oximetry, obtain an IV access, and if available, get an early ECG. At the same time, continue to assess if there are any hypoperfusion symptoms like hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. No such symptoms, continue to monitor and observe. If any such symptoms, you can give atropine IV dose. First dose atropine 1 milligram IV given. After that, repeat every 3 to 5 minutes up to a maximum of 3 milligrams. If atropine is ineffective in sustaining an increased heart rate, you can try transcutaneous spacing if the facility is there, or go on to give infusion dopamine at 5 to 20 microgram per kg per minute, or epinephrine at 2 to 10 microgram per minute. At the same time, consider shifting into a high center where transvenous spacing is available. In an ophthalmic setup, talking about bradycardia, you have to always mention the ocular cardiac reflex. It's also termed as a trigeminal reflex, and is defined by decreasing the heart rate by greater than 20% following low pressure or traction of the extraocular muscles. This reflex has most notably been noted in the squint surgeries, or also in the facial trauma and regional anesthetic nerve blocks. This is the ocular cardiac reflex pathway. The stimulation of the trigeminal nerve leads to activation of the motor nucleus of vagus nerve, leading on to suppression of synovial node, causing bradycardia. The incidence is 14 to 90%, and it decreases with increasing age. Therefore, pediatric population are at most risk of having this ocular cardiac reflex. Triggering factors can be any stimulus, direct pressure, or a nerve traction, muscle traction, ocular manipulation, ocular pain, increased pressures, blocks, hematomas, and trauma. The complication, a varying number of cardiac rhythms can happen, sinus bradycardia to cardiac arrest, and other symptoms due to activation of the vagal nerve. Prevention and treatment, only definitive treatment is immediate cessation of the triggering stimulus. Since it is a fatigable reflex, repeated stimulus will flatten the reflex. The other pharmacological management can be tried, which are intravenous anticholinergics such as atropine or glycopyrrolate, and the other thing is blunting the afferent limb of the reflex by giving a block, either retro or peribulbar blocks. Remember that retro and peribulbar block in itself can cause ocular cardiac reflex. The tachycardia, heart rate in adults that is greater than 100 beats per minute. Tachycardia can be due to fever, shock, medication, stress, metabolic dysfunction, hypoxemia. Whenever a heart beats too fast, that is more than 150 beats per minute, the ventricles are not able to completely get filled with the blood, leading to decreasing cardiac output and poor perfusion, and causing hemodynamic instability. This is an adult tachycardia with the pulse or the algorithm. Whenever the heart rate is more than 150 beats per minute, assess the appropriate of the clinical condition for this heart rate. Go on and identify and treat underlying causes. Maintain a patent airway, assess breathing, and support breathing as and when necessary. Oxygen, if the saturation is less than 94%, supplement with oxygen, monitor the blood pressure and pulse oximeter readings. Always assess for the signs of hypoperfusion, such as hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. If any of such symptoms are there, go for a synchronized cardioversion, or you can consider adenosine also. If there are no such symptoms, assess whether the QRS is wide or narrow. If there is a wide QRS complex and it is monomorphic ventricular tachycardia, then you can ventricular tachycardia, you can give antiarrhythmic infusions. If there is no wide QRS complex, then you can try vagal maneuvers if it is a regular rhythm. Then you can try adenosine or beta blockers and go for an expert opinion. Synchronous cardioversion, the different doses that are recommended for different types of arrhythmia are narrow, regular, supraventricular tachycardia is 50 to 100. Narrow irregular will be atrial fibrillation or atrial flutter, which is 120 to 200 joules biphasic or 200 joules monophasic. Wide regular will be 100 joules, and wide irregular will be ventricular fibrillation. So you have to give a defibrillation without synchronization. Adenosine can be given in the first dose 6 milligrams rapid IV push followed by a normal saline flush. If the rhythm is not reverted, then you can go for a second dose with 12 milligrams rapid IV flush. So antiarrhythmic infusion for stable white QRS complex that can be given are procainamide, amiodarone, or sotalol. Coming to a cardiac rhythms without pulse, whenever you see the person who has arrested without a pulse, immediately start high quality CPR. There can be two types of rhythm which can be found in these patients, a shockable or a non-shockable rhythm. The two shockable rhythms are ventricular fibrillation and ventricular tachycardia. Ventricular fibrillation, common cause of out of hospital or unwitnessed cardiac arrest, presents as a wavy disorganized line as shown in this picture. Another rhythm, shockable rhythm, is pulseless ventricular tachycardia, presents as a wide, regular, and very rapid rhythm without any pulse. Treatment is defibrillation with the 200 joules biphasic or 360 joules monophasic. Continue with the high quality CPR after shock. And you can give intravenous epinephrine 1 milligram every 3 to 5 minutes, or can consider amiodarone 300 milligrams followed by a repeat dose of 150 milligrams, or lignocaine 1 to 1.5 milligram per kg. Asystole is a non-shockable rhythm, sometimes referred as a flat line on the monitor. Whenever you see a flat line on the monitor, always double check the leads are connected properly. Then you will go on to make a diagnosis of asystole. The other non-shockable rhythm is pulseless electrical activity. It can be any activity on the ECG monitor without any palpable pulse except fibrillation or asystole. So in an non-shockable asystole or pulseless electrical activity, you will continue with high quality CPR. We can give epinephrine IV every 3 to 5 minutes, 1 milligram, and continue to check the rhythm every 2 minutes. You should always look into reversible causes of the arrest, like the 5H and 5Ts, and try to correct them. Panic attack requires a special mention in this condition because it can pose a difficulty in diagnosing the arrhythmias and its causes. So panic attack is presents a palpitation, sweating, trembling, lack of air, chest pain, and all. So normally whenever you evaluate a person with a panic attack, there will be some sort of attack in the past and some sort of phobia associated with it. And there can be some medical condition which can trigger a panic attack, the thyroid, asthma, heart problem, neurologic symptom, or substance abuse. Medication that can abate a panic attack, acute panic attacks, anti-anxiety drugs, especially the benzodiazepines, IV, can be given. Beta blockers and antidepressants are for long-term use. There can be non-pharmacological therapy like psychotherapy can be used for panic attacks. Conclusion: an arrhythmia can present in any form at any point of time. The primary aim, although, is correcting the rhythm. A detailed background checkup into the cause and treating them goes a long way in preventing further attack. Thank you.
Doctor, you are in mute.
Thank you, Dr. Anup, for a well said talk on, especially on panic attack, which is we see it very often and very well covered. Our next speaker is Dr. Vinita SK, a very young, dynamic anesthesiologist from the Institute of Diabetes and Eye Care, which is a unit of Shraddha Eye Care Trust, a charitable initiative of Netradama. Over to Dr. Vinita. Her topic is hypoglycemia and management of diabetes mellitus.
Good evening. My talk today is on diabetic emergency. I will be talking mainly about hypoglycemia and its management. At the outset, I would like to thank Karnataka Ophthalmic Society for giving me an opportunity to deliver this talk. Hypoglycemia, as we know, occurs due to a relative excess of insulin in blood in comparison to blood glucose. The level of blood glucose at which symptoms occur can vary from patient to patient, and it can range from just being a mild lowering of blood glucose with minimal symptoms, which usually occurs at a capillary blood glucose level of 70, to more severe hypoglycemia, which occurs at less than 40 milligrams per deciliter, and this usually presents with neurological symptoms. It's important to know that hypoglycemia is not diagnosed based on an absolute blood glucose level. Instead, it requires the fulfillment of a Whipple's triad. There should be signs and symptoms consistent with hypoglycemia. There should be associated documented low blood glucose level, and there should be relief of symptoms on administration of supplemental glucose. The signs and symptoms of hypoglycemia mainly occur due to two reasons. The adrenergic symptoms occur as a result of excessive sympathetic stimulation in response to falling blood glucose level. This can present with anxiety, pallor, excessive sweating, or tachycardia. And the neuroglycopenic symptoms, usually occurring due to the low central nervous system levels of glucose, present mainly with neurological symptoms in the form of altered mental state, impaired concentration, confusion, disorientation, or slurred speech. If untreated, it progresses to more serious symptoms like focal seizures and chorioathetosis. The rate at which the adrenergic symptoms are manifested depends upon the rate of fall of blood glucose levels. That is, more acute onset of hypoglycemia tends to produce more pronounced adrenergic symptoms. Adrenergic symptoms tend to precede the neuroglycopenic symptoms as an initial warning system to the patient about impending more serious hypoglycemia. If hypoglycemia has not been treated adequately at this stage, then the medullary phase can set in, where very low blood glucose levels of less than 10 milligrams per deciliter can exist, and patient can present with deep coma. At this stage, if treatment does not occur, patients tend to have more permanent neurological deficits and impairment. Risk factors for hypoglycemia are many. As we know, type 1 diabetic patients have an absolute lack of insulin, which puts them at a risk for diabetic ketoacidosis. However, they are also at risk of hypoglycemia because they tend to have impaired counter-regulatory mechanisms. Islet cell secretion of insulin is a potent stimulus for counter-regulatory hormone like glucagon to be secreted. Hence, impairment of islet cell secretion can impair the counter-regulatory hormone that is glucagon function as well. In the inpatient setting, the most common cause of hypoglycemia is a mismatch between the caloric intake and the timing and administration of insulin. Several other risk factors like chronic kidney disease, chronic liver disease, excessive alcohol intake, or malnourishment can all deplete the glycogen stores in the patient, and the first line of defense against hypoglycemia can be impaired. So these are all a risk factor for hypoglycemia. Any intake of drug in the clinical setting, that is adrenergic blockers, which will mask the initial symptoms of hypoglycemia, and intake of oral hypoglycemic agents like long-acting sulfonylureas can all predispose the patient to hypoglycemic events in the perioperative period. However, the most common cause of hypoglycemia in the perioperative period is a prolonged NPO status in anticipation of surgery, especially when it is in an unplanned setting. How do we avoid hypoglycemia in the perioperative period? All patients, especially diabetics, needs to have a thorough preoperative evaluation, irrespective of what kind of anesthetic they're coming for, because they need to be given a correct and a clear advice on how to manage their insulin and anti-diabetic agents in the perioperative period. At this point, it's also important to ask for the history of any hypoglycemic events in the past, how recurrent it has been, and how serious it has been. All the diabetic patients need to be posted as the first case of the list, and once they are admitted and once the NPO status is initiated, it's important to check capillary blood glucose levels every 4 hours both intraoperatively and postoperatively up until the time patient can resume the regular food intake. Treatment of hypoglycemia is, as with any other medical emergency, we approach it by the airway, breathing, and circulation approach. Once it is established that the patient is responsive and hemodynamically stable, we can take history from the patient regarding when the last dose of insulin was, the timing and the amount of last food intake, and we can also quickly do an assessment for presence of any IV access. A capillary blood glucose level at the bedside has to be checked in order to document the severity of hypoglycemia. This is an algorithm showing the treatment of hypoglycemia in clinical setting. If there is clinically symptomatic hypoglycemia with documented capillary blood glucose level equal to or less than 70, the first question we need to ask is the patient responsive? If the patient is not responsive, then an immediate IV treatment of hypoglycemia with 25 grams of glucose, that is 50 ml of 50% dextrose, is to be initiated. If the patient is responsive and if the patient needs to be NPO for any reason, then again, an IV treatment of hypoglycemia is to be established with 50% of dextrose. In both the settings, if an IV access is not available, then glucagon 1 mg IM is the way to go in order to immediately and promptly treat hypoglycemia. However, if the person is not unconscious and if the person does not require to be NPO, then oral treatment of hypoglycemia can be considered with 15 to 20 grams of oral carbohydrates. By this, I mean giving the patient around 4 ounces or 125 ml of non-carbonated or non-fizzy sweetened drinks like an apple juice or an orange juice. Or if the person is able to take a meal immediately, it has to be ensured that this is done. And irrespective of whether the oral or IV treatment of hypoglycemia was initiated, it is important to recheck the capillary blood glucose level within 15 minutes. If the patients have complete resolution of symptoms and if the capillary blood glucose level is more than 70, then we just need to do ongoing monitoring of the patient for any subsequent episodes of hypoglycemia. At the same time, ensure that the patient takes the meal and also try to evaluate the etiology of that episode of hypoglycemia and ensure that the future such episodes do not occur by educating the patient on how to recognize symptoms at the earliest basis. Irrespective of whether the patient has had an oral or an IV treatment of hypoglycemia, almost near complete resolution of symptoms occurs very quickly as soon as the treatment is initiated. With IV treatment, within 5 to 10 minutes, there is near complete resolution of symptoms and the patient becomes asymptomatic. If there is persistent symptoms in spite of repeated doses of dextrose at 30 minutes, it is important to consider other causes of neurological deterioration and refer the patient for further assessment and evaluation at this point. 50% dextrose is a highly irritant solution, and it's important that we give it via a wide bore cannula or with a proximal vein. In the initial setting of hypoglycemia, it's important that we do not initiate treatment with 10% or 5% dextrose because there is a risk of fluid overload at that stage. Once the euglycemia has been achieved, ongoing maintenance therapy can be maintained with 5 to 10% dextrose if a subsequent episode of hypoglycemia is expected. However, it's important not to be aggressive and swing the pendulum to the hyperglycemic side. Take a pragmatic approach and try to maintain blood sugar levels at less than 200 at all times. It's important to prevent subsequent episodes of hypoglycemia by giving appropriate orders of insulin and anti-diabetic agents in the perioperative period. Regular monitoring of capillary blood glucose at the bedside every 4 hours. Educating patient about symptom recognition and early and appropriate treatment initiation. Avoiding excessive NPO status, which is unnecessary in the post-operative period, and having diabetic patients take their regular meal at the earliest possible point, and also having systems in place in order to avoid medication errors in the hospital is important to avoid hypoglycemic events. Thank you.
Thank you, Dr. Vinita. That was a lovely physiological progression of symptoms and management. Very well said. And it's very important to remember they come under the vulnerable group, the vulnerable patient policy. So tagging them and identification of diabetics as a vulnerable group in an organization is very, very important, especially in ophthalmic setup. Let me welcome our next speaker, and the topic is Hypertensive Crisis and Acute Pulmonary Edema Management. And the speaker is Dr. Iris M.C. Rajiva. She's a vitreoretinal anesthesiologist with an experience of almost 25 years, and she is now with the Retina Institute of Karnataka. Over to Madam.
Good evening, friends and colleagues. I bring you greetings from Retina Institute of Karnataka. Today I am speaking on acute hypertension, crisis, and ophthalmic surgery. The incidence of hypertension is most prevalent in more than 50% of ophthalmic surgery patients. They have long-standing hypertension associated with coronary artery disease, stroke, dementia, renal disease, vascular disease, hypertensive retinopathy, and neuropathy. They are on concurrent antithrombotics too. In hypertension, there is left ventricular hypertrophy, and these are the various end organ damage that's produced by hypertension. Hypertension more than 180 by 120 is considered as hypertensive crisis. There are two types of crisis. One is urgency and the other one is emergency. In the first one, there is markedly elevated blood pressure without severe symptoms or progressive target organ damage. BP can be reduced with oral agents within hours. In hypertensive emergencies, markedly elevated blood pressure occurs with acute or progressive target organ damage. BP should be reduced immediately with parenteral agents. The predisposing factors are cardiovascular hypertension, diabetes, and smoking, which leads to acute blood pressure and acute volume, causing increase in the left ventricular end-diastolic pressure and pulmonary edema. In hypertensive crisis, this is the pathophysiology, where the increase in blood pressure causes a failure of autoregulation. This causes an increase in resistance, causing increase in vasoconstriction. This leads to a prothrombotic state. And there is endothelial injury. There is activation of the renin-angiotensin-aldosterone system. The endothelial injury causes ischemia and target organ damage. This progresses to congestive heart failure. Congestive heart failure causes most common signs and symptoms are fatigue, edema, shortness of breath, and chest pain. This is the alveolar capillary where oxygen and carbon dioxide exchange takes place. Here there is buildup of fluid causing pulmonary edema. In acute pulmonary edema, the patient should be made to sit up and the vitals should be monitored. The systolic blood pressure is more than 100. Sublingual glycerol trinitrate should be given every 5 minutes. If there is evidence of fluid overload, give 40 mg of furosemide. If the oxygen saturation is less than 92%, give oxygen, and if it doesn't improve, provide CPAP or BiPAP. we have to find out whether the patient has got acute symptoms and signs of acute end organ damage. If the patient is critically ill, consider giving sodium nitroprusside. If there is angina, give a beta blocker in addition. For pulmonary edema and urologic emergencies, nitroglycerin and nicardipine can be considered. If the patient is being actively treated for congestive heart failure, also you can consider sodium nitroprusside if the BP is high. If the current BP is less than not high, immediate treatment is not necessary. If it is high, you can consider intravenous labetalol, metoprolol, or intravenous hydralazine. These are drugs commonly given for hypertension. In hypertensive acute pulmonary edema, the patient can present with tachycardia and a blood pressure of more than 180 with bronchi and crepitations in the lungs. Oxygen supplementation improves the work of breathing, increases the intrathoracic pressure with reduction in preload and afterload. And nitroglycerin is given to reduce the afterload and at high doses, which causes vasodilatation more than venodilatation. ACE inhibitors are given to provide continuous afterload reduction. When there is pressure overload, ischemia, hypertrophy, and myocardial infarction, there is abnormal relaxation and increased stiffness. This can cause abnormal early filling, leading to diastolic abnormalities, or elevated LV filling pressures, causing reduced exercise tolerance and diastolic dysfunction. It also can cause elevated left atrial pressure and left atrial size, leading to atrial fibrillation, decreased cardiac output, and reduced exercise tolerance, causing congestive heart failure and diastolic heart failure. Now, how do we prevent all these? In our ophthalmology practice, a lot of sympathomimetics are used, like ephedrine and phenylephrine, which causes tachycardia and dysarrhythmias. The methods to reduce systemic side effects of topical drugs is to use the double dot technique, where it is don't open eyes technique and digital occlusion of the tear duct. This picture shows how the lacrimal sac and the punctum is occluded. Here, this is what we do in our institution. When the dilatation is not sufficient, after giving the block, the punctal occlusion is done. Safe approach during ophthalmic regional blocks is to premedicate and sedate the patient with midazolam, melatonin, or alprazolam. In a hypertensive patient, include atenolol and, if necessary, a calcium channel blocker. If the patient is already on a beta blocker, the premedication is tailored accordingly. Tune your ears with the ECG beeps on the monitor. This is how we are putting sublingual nicardia in the operation theatre if required. Addressing the patient's pre-op stress and improves the final post-op outcome. Daycare new patients experience significantly higher levels of pre-op stress and anxiety than do inpatients. So recommendations are the pre-op assessment of stress, anxiety profile by providing appropriate counseling and preconditioning. So the patient should be given reassurance and patient education and patient counseling. This will all go a long way to busting the anxiety. We have come a long way, yet there is a scope to refine further. Thank you. Should I say it again?
No, that's nice.
Good.
This was
Thank you very much, Dr. Iris. That was a very well pictorial and very well represented presentation. Our next topic is adverse drug reactions by none other than Dr. Jayachandran himself. I have already given an introduction to him. We can start with his presentation.
Good afternoon, everybody. Myself is Anesthetist Dr. Jayachandran VV. At the outset, I would like to thank the Karnataka Ophthalmological Society for having given me this opportunity to talk on a most important topic, that is adverse drug reaction. WHO defines adverse drug reaction as a response to a drug that is noxious, unintended, and occurs at doses normally used for prophylaxis, diagnosis, or therapy of disease or for modification of physiological functions. There are totally 5 types of adverse drug reactions that are reported to occur. Type A is augmented, that is dose dependent. Say, for example, if a patient is given too much of antihypertension, it can result in hypotension. Type B is bizarre type of reaction, that is dose independent, and it can be due to an allergic or idiosyncratic reaction. Type C is chronic, when the patient is taking a drugs for a long period. For example, analgesic resulting in interstitial nephritis. Type D is delayed, thalidomide resulting in teratogenesis effect. And type E is withdrawal and rebound. Say, for example, insomnia and anxiety disturbances following benzodiazepines withdrawal. Now, today in this presentation, I will be sharing mainly the allergic and idiosyncratic type of reaction, and at the last I will be talking about type A reaction also. Allergic reaction in an ophthalmic setup can occur due to intravenous fundus fluorescent angiography, where the patient can develop nausea, vomiting, sneezing, itching, transient palpitation, chest tightness, dizziness, and cold sweat also. And allergic reactions in the OPD can occur due to installation of eye drops. The most important thing is allergic reactions to local anesthetics occurring in the perioperative area. Literature reviews totally shows about 4 cases of lidocaine hypersensitivity in ophthalmology. The first one is due to subconjunctival injection. The other one is due to peribulbar local anesthesia, where a 70-year-old woman complained of a sight-threatening acute orbital swelling, and potentially blinding adverse drug reaction to peribulbar lignocaine anesthesia have been reported, where in this case the patient developed a total optic atrophy. Also, an immediate reaction to lidocaine with periorbital edema during upper blepharoplasty has been reported. Half late, allergic reactions to local anesthetic adjuvants, namely hyaluronidase, have been reported in a large numbers. And this is one of our presentation where we had a total of 5 cases, and all these patients presented with periocular edema, proptosis, and restriction of ocular movements. And one patient had a compartmental like syndrome also, where we did an emergency canthotomy, and rest of the patients were treated with IV steroids and anti-allergic medications. CT scan demonstrated mild proptosis of the left eye, and also there was a mild to moderate thickening of the left extraocular muscles. On literature review, nearly about 40 publications are there, where there have been hypersensitivity reactions to hyaluronidase have been reported following retrobulbar, peribulbar, and subtenon block. The incidence is quoted to be somewhere around 0.05 to 0.69%. Here, this is a total review of allergic reactions to hyaluronidase, where we can see that localized signs and symptoms like proptosis, erythema, and extraocular muscle dysfunction has been reported, and systemically patients can develop angioedema, itching, tachycardia, dyspnea, anaphylactic shock also. The time of onset of reaction can be variable. It can be immediate, it can be early, intermediate, or sometimes it can be occurring within weeks also, that is called as late. Now, many of these patients had undergone an earlier surgical procedure that included hyaluronidase use, which suggests that these reactions might be the result of sensitization to the animal-derived product. Mechanism of reaction, namely two types they say. One is due to type 1 immediate hypersensitivity reaction. This is IgE mediated. It is mainly involves mast cells and basophils. Reaction is said to occur within 15 to 30 minutes from the time of exposure. Type 4 is delayed T cell mediated, where there occurs release of lymphokines and macrophage activation. Here we can see one of our patients developed a contralateral periorbital edema with mild puffiness of the face and earlobe swelling immediately following surgery. And this was a picture taken on the first post-operative day and third post-operative day. And the same patient, you can appreciate here the intradermal skin test for Hyalase being positive here. You can appreciate the redness and induration here. Differential diagnosis includes retrobulbar hemorrhage and orbital cellulitis. Now, how to differentiate these? Orbital swelling, if it occurs immediately, then it is mostly due to a retrobulbar hemorrhage. CT scan, of course, can help you to differentiate between these two conditions. In case of orbital cellulitis, associated pansinusitis can be an incidental finding, or there can be any active sinus infection or purulent septic foci. Associated fever, pain, erythema can be there, and altered blood count, raised ESR and CRP can be associated features if it is an orbital cellulitis. Now, how to diagnose type 1? Mainly by intradermal or skin prick allergic test, positive for hyaluronidase, whereas it is negative for all the other perioperative medications. Thus, in this picture, we can appreciate that it is negative for lignocaine, bupivacaine, and also a patch test being performed for citavolon is also negative, whereas we can see here for Hyalase and positive reaction occurring. Also, there are some serum IgE antibodies highly specific to hyaluronidase that can be detected. Type 4 means lymphocyte transformation test can be performed, and CT scan, as I was mentioning, also helps in the diagnosis. Now, once the diagnosis has been established, coming to the treatment part, it involves mainly IV antihistamines and steroids. In the presence of any compartmental syndrome, lateral canthotomy can be performed. Visual acuity, pupillary reaction, and extraocular movement should be monitored throughout. If it is an anaphylaxis like signs and symptoms, then it has to be treated on emergency basis. Epinephrine will be the drug of choice. 0.3 to 0.5 milligram intramuscularly is given, preferably in the mid-outer thigh, and it can be repeated every 5 to 15 minutes. Airway should be maintained, and place the patient in recumbent position. Give oxygen 8 to 10 liters per minute. Normal saline rapid bolus can be given if there is an associated hypotension. For bronchospasm, nebulization can be done with beta blockers. Then also antihistamines, diphenhydramine 25 to 50 milligram IV should be given. Steroids. Then monitoring includes non-invasive hemodynamic monitoring and pulse oximetry monitoring should be done. Urine output also should be monitored. Of late, at our institution, we are now included this preoperative allergic skin test, where half an hour before surgery, we perform this intradermal skin test to all patients who are allergic to food, insect bite allergy, allergic to any medicines, allergic rhinitis, allergic skin disorders, where we give 0.2 to 0.3 ml of 2% lignocaine with 12.5 international units of hyaluronidase in one forearm. If the response is negative, we perform the surgery. Suppose if there is a positive response in the opposite forearm, we again perform the intradermal skin test separately for Zylocard, Hyalase, and ropivacaine. And if there is any positive, then accordingly we choose the local anesthetics and perform the surgery. Now, this is a typical example for a type A reaction that is augmented, where there is a cases of postoperative periorbital swelling owing to hyaluronidase used at a larger dose. And here they have reported a total of 7 patients. In all these cases, we can appreciate here a dose of hyaluronidase used was somewhere around 50 to 250 international units per ml. And all these patients, they showed negative allergic test. Thus, they are diagnosed as a type A reaction. Also in this eye journal, an orbital swelling following peribulbar and subtenon anesthesia owing to hyaluronidase excess dose have been reported. Now, the British National Formulary recommends a safe hyaluronidase dose as 15 international units per ml for ophthalmic blocks. At our institution also, we use hyaluronidase at around this 15 international units per ml. Now, coming to the prevention of acute adverse drug reaction, always it has to be reported as an incident. Thorough evaluation should be done by multidisciplinary team members. Cause for the reaction should be established. Regular educational program must be carried out. Remember, publishing it in medical literature will increase the awareness. That is most important. To conclude, adverse drug reaction in an ophthalmic setup can occur anywhere. It can be at OPD, it can be at OT, it can occur due to eye drops, FFA. Remember, most importantly, it is due to the local anesthetics and adjuvants. Careful preoperative history taking is very important. Look out for always for allergic signs and symptoms. Be prepared. IV line should always be established. Emergency crash cot and airway equipment should always be kept ready. Once, if you are diagnosed with adverse drug reaction, report it and publish in medical literature so that it can increase the awareness among the healthcare professionals. Last but not the least, to know about more about the systemic complications and its management, I would like you all to go through this book, that is Principles and Practice of Ophthalmic Anesthesia, that have been brought out by us in the year 2017, and happy to share that Dr. Shuman Sri, who is also a moderator for this session, is also one of the authors in this book. Thank you all.
Thank you very much, Dr. Jayachandran. It was definitely a very relevant topic. We are seeing this every other day, high-less reactions. And now we know how to manage this, and especially how importance of reporting these incidents. And very well researched presentation, I must say. So thank you very much. We're deeply honored to have you as one of our speakers. Let us move on to the next topic, perioperative bronchospasm. We are in Bangalore, the allergic city of India. So we see it very often in our clinical practice. And we have a very senior consultant, Dr. Parimala B, very dynamic anesthetist too. She is with NU Hospitals Trust. She was also one of our consultants at Netradama. And she has 15 years of experience. She has more than 3-4 publications. And she's a gold medalist in her anesthesia PG program. Over to Dr. Parimala.
Good evening, everyone. Dr. Parimala here from NU Hospitals, Bangalore. I would like to thank Dr. Ilan Kumar and QoS for providing this opportunity to be here for this presentation. My topic for discussion is perioperative bronchospasm. It's a very vast topic to be covered in 10 minutes. So I'll keep my discussion relevant from ophthalmic point of view. Starting with basics, perioperative bronchospasm is narrowing of airways resulting in decreased lung compliance in the preoperative, intraoperative, or postoperative period. In preoperative period, bronchospasm may present as cough and breathlessness. In the intraoperative period under general anesthesia, it presents as prolonged expiration with increased peak airway pressures, which is heard as an alarm on the anesthesia monitor. The complications of perioperative bronchospasm are hypoxia, hypercapnia, hypotension, leading on to increased morbidity and mortality. The complications are significant and serious under general anesthesia and may be relatively less concern under regional anesthesia, nerve blocks, and local anesthesia. And what is the most common type of anesthesia used for ophthalmic surgery? It is nerve blocks or local anesthesia, and now we have even moved on to topical anesthesia. IV sedation and GA are used for some long procedures or uncooperative patients or in pediatric patients. So when we are doing all procedures under blocks and local anesthesia, should we be really concerned about bronchospasm in ophthalmic surgery? Let's discuss this. What are the unique requirements of ophthalmic anesthesia and surgery? Maintenance of intraocular pressure is the cornerstone of ophthalmic anesthesia. Along with that, immobile patient, ability of the patient to lie supine comfortably, no cough or bucking are essential requirements for ophthalmic surgery. Control of intraocular pressure before, during, and after the procedure is important because increase in intraocular pressure results in optic nerve ischemia and bleeding complications. So the reason why we are concerned about bronchospasm in ophthalmic surgery is that it causes coughing, breathlessness, raised central venous pressure, hypoxia, and hypercapnia, all of which increase intraocular pressure. How? A brief explanation. Coughing increases intraocular pressure by 40 to 60 millimeters of mercury and is also associated with significant patient and head movements, which makes surgery challenging. Also, when patients are breathless, they can't lie supine and they start moving or become apprehensive, especially when the head is draped for the surgery. Persistent bronchospasm results in right heart failure, thereby increasing central venous pressure and hence IOP increases. Hypoxia causes dilatation of the choroidal blood vessels and increases choroidal circulation, resulting in increased IOP. Bronchospasm is associated with prolonged or incomplete expiration, resulting in carbon dioxide accumulation, causing hypercapnia, respiratory acidosis, result increased IOP. So all the symptoms and complications of bronchospasm will increase intraocular pressure and hence affect the outcome of the ophthalmic surgery. Because of this reason, a proper preoperative evaluation with focused perioperative intervention becomes very important to prevent the effect of bronchospasm in the intraoperative and postoperative. We'll now discuss management of bronchospasm. This will be discussed under two headings. One is preoperative optimization and the other is intraoperative bronchospasm management per se when the complication occurs. Under pre-op optimization, optimization of lung function and optimization of therapy, both are of importance. So preoperative optimization of lung function, this involves a discussion on smoking. Smokers need to quit smoking in the preoperative period because smoking increases bronchial secretions, decreases mucociliary clearance, and also has effect on the immune functions. Ideally, smoking has to be stopped 6 weeks prior to surgery. However, if that much time is not available, whatever time duration is available, stopping smoking has been proven to be beneficial. Incentive spirometry increases the lung capacities, thereby helps in better oxygenation and removal of carbon dioxide. Physiotherapy is very useful in bronchiectasis cases where a lot of secretions needs to be removed, and also physiotherapy helps in opening up the collapsed alveoli, so helps in better oxygenation. A course of appropriate antibiotics helps in preventing respiratory infections in the intraoperative and postoperative period. Coming to optimization of therapy, commonly used drugs to treat bronchospasm are inhaled beta-2 agonists and steroids. all patients of bronchial asthma are generally on one or other type of inhalers. The common inhalers used are inhaled beta-2 agonist. This is the mainstay of treatment for bronchospasm. Commonly used drugs are long-acting beta agonist like salmeterol or short-acting beta agonist salbutamol. Inhaled steroids are also used as first line of drug for bronchospasm because of its anti-inflammatory action. They may be used inhaled form like budesonide and fluticasone, or even systemic steroids like prednisolone, methylprednisolone are used for severe cases of bronchospasm. The other supplementary drugs used are montelukast, has been proven to be very beneficial in preventing episodes of bronchospasm. Ipratropium helps to reduce secretions. Mast cell stabilizers are helpful in exercise-induced asthma. And methylxanthines continue to be used in spite of significant systemic side effects. Now let us discuss a practical stepwise approach when a patient with known history of bronchial asthma comes for a surgery or for pre-anesthesia checkup. We have categorized patients into 4 categories depending on their symptoms and the treatment they are on. And then look at what additional treatment is required. First category of patients, they have no symptoms and are not on any regular treatment. So they may have some episodes of wheezing during seasons. These patients can be taken up for surgery without any empirical treatment. The next category is patients who are free from symptoms for last 3 months and they are on regular inhaled beta-2 agonist and steroids. In these patients, continue their inhaled therapy and add a nebulization with beta-2 agonist and steroids before shifting to OT. The next category is the patients who have recent increase in symptoms and on regular inhaled long-acting beta-2 agonist and steroids. So in these patients, you have to continue their inhaled therapy, along with that add inhaled short-acting beta agonist and also a short course of oral steroids 3 to 5 days before surgery. The last category of patients are those who have persistent daily severe symptoms in spite of being on regular inhaled long-acting beta-2 agonist, steroids, and systemic steroids also. These patients need surgery to be rescheduled and continue all the treatment plus bridge with the frequent nebulized doses of short-acting beta-2 agonist and high dose of steroids may be required, especially 3 to 5 days of IV steroids is used in these patients before surgery. Now, management of intraoperative bronchospasm when it happens on table. Under regional anesthesia or nerve blocks, like in ophthalmic setup, we put patient on oxygen mask, stop surgery for a while if possible, and administer IV steroids and methylxanthines, nebulizations with beta-2 agonist and steroids, inhalers which the patient have been using in the preoperative period is very helpful. If bronchospasm does not settle with all above measures, a small dose of IV adrenaline is very useful. However, awake patients, very difficult to tolerate the side effects like tachycardia. And when bronchospasm happens under general anesthesia, it's a life-threatening complication because ventilation is compromised significantly, thereby affecting oxygenation. So hypoxia sets in. Stop surgery, ventilate the patient with 100% oxygen, and all our volatile agents, anesthetic agents are bronchodilators. So deepen anesthesia with volatile agents and use other bronchodilators like ketamine, which are immediately available on table. Inhaled beta-2 agonist is attached to the inspiratory limb of the ventilatory circuit. so that the beta-2 agonists reach the lungs along with the ventilation and help in bronchodilation. IV steroids is used. Again, in resistant cases, the drug of choice will be IV adrenaline, 1 to 2 micrograms per kg, which shows a significant improvement immediately. To summarize, bronchospasm rarely causes life-threatening complications like hypoxia, hypotension under nerve blocks and local anesthesia. But still, it is of major concern because it causes cough, breathless, making patient uncooperative for surgery under blocks and local anesthesia. And also all this increase IOP, thereby affecting the surgical outcome. So preoperative optimization of lung function is the key for successful outcome of the surgery. Thank you.
Thank you very much, Dr. Parimala. That was a lucid and a very clear management line for bronchospasm. And in fact, we have a nebulizer on crash cart itself. It's so important. And I guess being forewarned is being forearmed. So very important to note it down in the pre-anesthetic evaluation that whether history of bronchospasm and being ready, prepared always. That was wonderful, Parimala. Thank you very much. We go on to our next topic, acute coronary syndromes, especially acute myocardial infarction. It's my privilege to welcome Dr. P.M. Chandrasekhara, who is a doyen in the field of anesthesiology with almost 50 years, is golden anniversary of anesthesia. We are very, very fortunate to have him amidst us. And he is a consultant, a cardiac anesthetist at Retina Institute of Karnataka. Over to you, sir.
Good morning. I am Dr. P.M. Chandrasekhar. I will be talking about cardiac morbidity in a patient with PMI. To start with, I will be bringing a greeting from Retina Institute of Karnataka, and my topic will be perioperative cardiac morbidity. And the scope is I will be presenting a case of PMI and how to manage the patient and also practice guidance. Here is a 68-year-old man scheduled to undergo MIVS. He has got IHD and hypertension, and a previous history of ICU admission, and is stabilized with the 2-vessel PTCA. He is on antihypertensive and clopolate, and occasionally he takes a nitroglycerin sublingually. And how you would fare during the surgery is, we know that following a non-cardiac procedure in a cardiac patient undergoing minor surgery, we will have perioperative cardiovascular complications, and we have to draw the evidence-based guidelines recommended by American College of Cardiology and Heart Association. Ischemic heart disease and coronary artery disease has attained an endemic stage called lifestyle disease or endothelial disease or atherosclerosis, associated with the longevity of life, diabetes, smoking, and obesity. Atherosclerosis has a genetic disposition also. It is the abrasion of vascular endothelium or edema, and we can do the gene sequence and also identify the risk factors. Review under consideration. Thus, one should not concentrate on heart alone. Retinal vessel illustrate the vascular endothelial changes. Like diabetes, ischemic heart disease is a part of end organ disease. Multi-organ system including brain, retina, carotid, retinal vessel, and peripheral vascular system should be evaluated. Atherosclerosis is also with other metabolic conditions like diabetes, obesity, and hyperlipidemia. These are the causes for this one. End organ disease of the vascular system. And heart attack occurs whenever there is a blockage of one of the coronary vessels, and it will cause muscle damage or ischemia, ending in infarction. It can be due to the plaque rupture of the thrombus or vasospasm or clot formation inside the. And now we have got a genome technology where we can identify the gene that is involved and also tell us when we are heading for ischemic heart disease about 10 years earlier. In India, 3 million die of cardiovascular disease every year. Heart disease is a primary killer in the country. 60 to 70% of the population is prone for cardiovascular disease. In India, the heart attack occurs amongst the youngsters with more severity and higher frequency. And mortality due to cardiovascular endothelial disease is twofold over the other diseases. Surgical patients above 65 is increasing by 100%. And also is an age-related disease. And also with present COVID situation, lifestyle disease is becoming more because of inactive lifestyle, contributes to higher blood cholesterol level and IHD and obesity. What is perioperative myocardial infarction or perioperative cardiac morbidity is, by definition, acute coronary syndrome following disruption of vulnerable plaque. Patient experiences ischemic comfort resulting from reduction of flow through the affected epicardial coronary artery. The pathology of the is plaque rupture in a non-critical stenosis, causing the total obstruction and resulting in myocardial infarction. And maybe it is the result of uncontrolled hypertension during surgery or severe tachyarrhythmia, severe anxiety, severe pain, and some of the drugs that we put into the eye, and also there will be a hypercoagulable state during surgery. And how the ischemia, if it is not results in necrosis of the tissue. These are the stages and also how they present to us during different stages, and how angina and acute coronary syndrome will occur when there is a total blockage. And here is a picture where the blood flow is totally occluded by the ruptured plaque. And also they may end up in congestive heart failure if it is not treated. And pathophysiology is because of the narrowing of the vascular endothelium as a results in hypertension and coronary artery disease. Vascular endothelium is the body's largest organ, the endocrine organ, 1 cell thick, and it has got 1 to 2 trillion endothelial cells. Surface area is 4 square centimeter, 6 tennis square, and weighs about 1.5 kg. And its function is control of the vascular wall function in response to the circulating chemicals and also pressure. And this is a complex picture showing how vascular wall gets damaged and what are the chemical reaction that takes place, resulting in vasoconstriction, leukocyte addition, platelet aggregation, and cell proliferation. We can have a risk stratification before subjecting a patient for surgery, and most commonly done is the exercise testing, provides information about the cardiac status, guides about the therapeutic strategy that you have to adopt before subjecting them for surgery, and also it gives a target heart rate and BP control during surgery and before surgery. This stratification also ascertain the atherosclerotic cardiovascular disease and what are the things that we can control before taking the case. Multivariable disease indicates the associated condition that we can evaluate during the surgery. And during physical examination, we look for the blood pressure at different position, look for jugular vein distension, auscultation, and lung also for pulmonary complications, presence of pacemaker ICD, and other conditions. Functional capacity is also we can assess before the surgery, what are the routine activities that he can attend, or he can climb a stair, or he can conduct strenuous exercise. Usually if we ask the patient can do daily run over 60 minutes, no more functional capacity tests are required. Echo assessment is very, very important non-invasive study. It gives the overall cardiac function, especially ejection fraction. If it is below 40, postoperative morbidity is assured. And ECG provides the basal record and it gives a clinical predictor of increasing perioperative risk and also tell us about the recovery after infarction. How the ST elevation occurs when a thrombus formation occurs and blocks this one. This gives the different scores about the ischemia, necrosis, and infarction. ECG also gives us the quality, quantity, and duration, and the age of the infarction. And we can also interpret the ischemia in different ways. And also we can localize which artery, coronary arteries blocked and what is the prognosis. During surgery, we'll be monitoring the ST segment analysis and it will give us the maximum changes that is taking place. And regarding the antiplatelet agents and whether to discontinue or continue during surgery, better to have an idea and discuss with the cardiologist or recommending the case, but usually there is no need to discontinue. What are the comorbid conditions that one could control is, especially in renal patients, they'll have accelerated hypertension and it is better to control the blood pressure as far as possible and take the surgery a day after following dialysis. Diabetes, we know that hyperglycemia and patients who are on insulin therapy are high risk and it's also endocrine disease. Perioperative therapy that we can give is start with the beta blocker. It's the rate control therapy and it will reduce the oxygen demand by the myocardium and it is recommendation is to continue the blockers. And calcium channel blockers, diltiazem is a vasodilator, again provides some better collateral blood pressure and blood supply to the myocardial ischemia. Statins are recommended because it will reduce the cholesterol level and will improve the platelet integrity. And these patients usually present with a preoperative surgery or balloon or and they may also give a history of shortness of breath and sometimes they may present with other complications like arrhythmias and tamponade. And overall management, if occurs, is recommended here, and we can send some sample for troponin estimation or to assess and refer the case to cardiologist. And IHT patient present for ophthalmic surgery poses a challenge of anxiety, cause for preoperative workup, meticulous optimization, preconditioning, and perioperative monitor anesthesia care, and postoperative follow. Successfully managed patient will be able to see better, and that's smile. Thank you. How much time?
Thank you very much, sir. That was a very crystallized presentation of a very tough topic, I must say, but very well said. I guess we have just covered all the pre-arrest scenarios so far. And now if an arrest has taken place, a code blue situation in the hospital, what do we do? So we go on to the last topic of this session, code blue, the BCLS and the CCLS Indian Resuscitation Council guidelines by me. You can go ahead with the presentation.
Good evening to one and all. At the outset, I would like to thank Dr. Ilan Kumaran for inviting me for this lecture. Code Blue, the BCLS and CCLS Indian Resuscitation Council guidelines. The various scenarios in an ophthalmic practice that may need cardiopulmonary resuscitation are a vasovagal attack or severe bradycardia leading to cardiac arrest, anaphylactic reactions during invasive procedures like FFA, a cardiopulmonary arrest during local or general anesthesia, acute coronary syndromes, including an acute MI, severe hypoglycemia, and even life-threatening cardiac arrhythmias during high-risk procedures like intravenous methylprednisolone. CPCR or cardiopulmonary cerebral resuscitation goals are to support and restore effective circulation, oxygenation, and ventilation with a return of intact neurological function. An intermediate goal is ROSC or return of spontaneous circulation. How do we diagnose an arrest? Patient is unresponsive, apneic or no normal breathing, and there's an absence of a palpable pulse in a large artery, usually the carotid artery. If it is a witnessed cardiac arrest on a patient with a cardiac monitor, the cardiac arrest rhythms could be ventricular fibrillation or VF, pulseless VTach or ventricular tachycardia, asystole or flatline, or pulseless electrical activity. So what do we do? C, A, B. C for chest compressions, A for the airway management, and B for effective breaths. The IRC guidelines of 2017 are based on the experience of the rescuer, the place of resuscitation, and the availability of facilities. We have three algorithms. COLS or compression only life support for outside the hospital by untrained laypersons, coded in yellow color. Basic cardiopulmonary life support or BCLS guidelines for outside the hospital by trained personnel in green color. Comprehensive cardiopulmonary life support or CCLS inside the hospital by trained personnel, coded in blue. Let us go to the COLS guidelines. The callings are early recognition and activation, early chest compression, and early transfer. This is how the algorithm looks. Basically, we ensure safe place, check for response. If patient is non-responsive, start chest compressions, 30 chest compression, 5 cycles, and again check for response till higher care is available. Now for trained personnel outside the hospital, the callings being early recognition and activation, early high quality CPR, early defibrillation, and early transfer. This is how the algorithm looks. Let's look at it in the upper half as it is split. First of all, ensure safe place. Hello, are you all right? Checking for response, tap on the shoulder. If they're responsive, observe the victim in a recovery position and shift to the nearest medical facility. If they're non-responsive, shout for help or code blue. Call 108 and ask for the crash cart and the defibrillator. Check the breathing while palpating the carotid pulse within 5 to 10 seconds. 3 options are possible. 1, there's a normal breathing with a definitive carotid pulse. Put them in a recovery position, reassess every 2 minutes, and shift to the nearest medical facility. Or you could have an abnormal or no breathing situation with a definitive carotid pulse. That means we have to provide rescue breaths. It is a respiratory arrest. We provide 1 breath every 5 seconds, reassess every 2 minutes. The third possibility is an abnormal or no breathing without a definitive carotid pulse. This is a cardiopulmonary arrest. You start cycles of 30 chest compressions and 2 breaths. 5 cycles, 30:2, after which we check the carotid pulse for not more than 5 to 10 seconds. And we go back to the cycle. Now, this is a pictorial depiction of how we go about BCLS. We check for response. Then if the patient is responsive, put it in the recovery position, left lateral position in this way. Now, if they are non-responsive, we activate code blue and we check for breathing while palpating the carotid pulse this way. Now, if chest compression is required, we locate the xiphisternum, place the heel of one hand, 2 fingers above it, put the heel of one hand over the heel of the other, interlock the fingers, and lock your elbows. deliver effective chest compressions at the rate of 120 per minute to a depth of 5 to 6 centimeters, allowing for complete chest recoil. Next, we look at the airway, the head tilt and the chin lift technique. This is to prevent the tongue from falling back and obstructing the airway. Later on, if we have certain airways like the oropharyngeal airway, we could use it, or the nasopharyngeal airway. We can measure it from the angle of the mouth to the angle of the jaw, and for nasopharyngeal, from the tip of the nose to the lobe of the ear. Next, we go on to breathing. That is, either it is mouth to mouth, or through a pocket CPR, or through an ambu bag. We use the C and E technique with our hands, and we do 30:2. If it's difficult to maintain the airway, we can also use an advanced airway like a laryngeal masked airway. This is the insertion technique. So the key messages being, we need to deliver each breath over 1 second and give 1 second pause. Start the chest compression immediately after the second breath. Importantly, switch your roles of chest compressions and breathing after the 5th cycle, that is 2 minutes. Now we look at the latter half of the algorithm. Once the defibrillator has arrived, we attach it, then we have to analyze it. While attaching the pads, don't stop the chest compressions. But while analyzing the rhythm, don't touch the patient. If it is a shockable rhythm, we press the shock button. We can start with 120 joules, escalate it to 200 joules. If it is an automatic external defibrillator, it is auto-selected. If it is not shockable, we resume high quality CPR. Continue the cycles till the victim becomes responsive. Either he moves, coughs, or vocalizes, or pulse and breathing returns. Then the victim is shifted to the medical facility. So various ECG rhythms in a cardiac arrest, which are shockable, are ventricular fibrillation, which looks like this, and pulseless ventricular tachycardia. The non-shockable rhythms are asystole and pulseless electrical activity. Once an AED arrives, we power on the AED. We attach the electrode pads to the victim's bare chest. We clear the victim. You are clear, I'm clear, all are clear. Then we analyze the rhythm, press the shock button, continue the CPR, starting with chest compressions. If you have a manual defibrillator, it could be biphasic or monophasic. We power it on, attach the chest lead, set the charge, biphasic 120 to 200, monophasic 360, children 2 to 4 joules per kg. Then we charge it, we place the sternal pad, the apical pad, I'm clear, you're clear, we're all clear, press the shock button and continue with CPR without interruption. Most importantly, the do's and don'ts are in adult CPR. We compress at 120 per minute, depth of 5 to 6 centimeters, allow full chest recoil, minimize pauses in chest compressions, and ventilate adequately. 2 breaths after 30 compressions, each breath delivered over 1 second, each causing adequate chest rise. Now we go on to comprehensive cardiopulmonary life support, or CCLS. This is inside the hospital. The callings being early recognition and management of pre-arrest conditions. Early recognition, activation of code blue, early high quality CPR, early defibrillation, and early comprehensive life support and post-resuscitation care. Well, the CCLS emphasizes the need to recognize patients at risk for cardiac arrest and their timely management before a cardiac arrest occurs. Basically, we need to have a high suspicion index for pre-arrest scenarios. The basic components include chest compressions for blood circulation, airway maintenance, lung ventilation, defibrillation to convert a pathological shockable rhythm to one capable of effective blood circulation. The CCLS emphasizes incorporation of airway management, drugs, identification of the cause of the arrest, and its corrections, while the chest compression and ventilation are going on. It also emphasizes the value of organized team approach and optimal post-resuscitation care. Now, this is how the CCLS algorithm looks. You will notice the first part and the middle part is the same as the BCLS algorithm. The only thing which changes is the lower 1/3 of the algorithm. So I have already completed the BCLS. Now we will go on to the simultaneously during the cycles of CPR, we need to ensure three things. One is venous access or intraosseous access if it's not possible, airway management considering definitive airway, drugs like administering 1 milligram of adrenaline intravenous, repeating every 3 to 5 minutes. Various antiarrhythmics are also considered for refractory VF and pulseless VTAC, that is amiodarone 300 milligrams IV bolus, second dose of 150 milligrams, and identifying the reversible causes and treating them. The mnemonic is hit the target. And all the time, please remember, high quality CPR, 120 per minute, one breath every 6 seconds. Very important aspect of CCLS is intravenous route is a preferred choice. Give the drug bolus, administer 20 ml bolus of IV fluid, elevate the limb for 10 to 20 seconds after giving the drug. Intraosseous is alternate route. Endotracheal route is a rescue choice. We have to give 2 to 2.5 times the IV dose, dilute in 5 to 10 ml of normal saline, and the drugs are in a mnemonic called alone. A for atropine, L for lignocaine, O for oxygen, N for naloxone, and E for epinephrine. We need to dilute 1 milligram of adrenaline in 10 ml of normal saline and administered as a bolus, repeated every 3 to 5 minutes. Administer while ongoing chest compression. If after initial 2 to 3 of such 5 cycles of CPR, arrhythmias persists, we have to give antiarrhythmic drugs like amiodarone, 300 followed by 150 mg, and other appropriate drugs to manage the rhythm and the blood pressure, like vasopressin, Zalokard, magnesium, dopamine drip, etc. So what are the reversible causes? Hit the target. H for hypoxia, I for increased hydrogen ions, that is acidosis, T for tension pneumothorax, T for toxins or poisons or toxicity or overdose, H for hypovolemia, E for electrolyte imbalances like hypo or hyperkalemia, T for cardiac tamponade, A for acute coronary syndromes, R for raised intracranial pressure like subarachnoid hemorrhage, G for glucose hypos or hypo or hyperglycemia, E for embolism like pulmonary or thrombosis, and finally temperature variation like hypothermia. These are the important contents of a crash cart, most important being your adrenaline and your atropine. And finally, if you've had a successful resuscitation, restoration of your cardiac rhythm, effective cardiac output through pulse and blood pressure, spontaneous respiration, pupils constricted and reactive, return of consciousness, and shifting the patient to the nearest ICU or CCU. This is how a code blue drill is conducted. There's a role play in the CPR team. We have team leader at the foot end, airway manager, ventilator at the head end, and on either side, we have the chest compressor, the monitor defibrillator, recorder on one side, and the venous access with medications on the other side. Now, how do we know when do we terminate a resuscitation? Once the reversible causes have been ruled out and corrected, based on clinical judgment, a decision can be taken to discontinue it. ETCO or capnography is a very good sign of perfusion, can be used for prognostication in intubated patients. With high quality CPR, an asystole for more than 20 minutes or ETCO to less than 10 millimeters of mercury can be considered as a sign to stop resuscitation. Well, in suspected COVID patients, you need to don PPE and you need to have a doffing area designated. In child CPR, if there are 2 rescuers, we can do 15:2, and chest compression techniques can be 2-finger or chest encirclage method, the rest being the same. Now, to summarize, we have COLS, BCLS, and CCLS core links. In NABH Eye Care Organization, NABH standards, we have COP3 or care of patient with 3 objective elements where we need to document policies, procedures, and how we go about CPR training program, and how do we document the post-event analysis in a recorded way. And this is how we do it in Netradama. We have a recorder sheet and post-event analysis. Thank you very much.
Thank you, madam. That was an exhaustive session. And for people who have not even seen, who have seen only drops as anesthesia, that was excellent. In fact, I would like to say the first time I had a vasovagal, I didn't know what to do for a minute or two. Though we were trained, this is what happened. Thanks for that excellent session from all the seniors, Dr. P.M. Chandrasekhar sir, Dr. Iris Rajiva madam, Dr. Vinita, Dr. Parimala, Dr. Jai Chandran, and thanks a lot. You put up this program in an excellent way.
Thank you very much, Dr. Elan, and for giving us this opportunity. I hope this saves lives and makes your life much better in all the ophthalmic practices. Thank you once again.
Thank you. Thank you, everyone. From systemic emergencies in medicine to almost instant successes, we're going to talk about refractive cataract surgery, and who else to chair the session, Dr. Sri Ganesh. Again, I introduced madam as the first anesthetist and my boss. He was my first boss to start the private practice. Over to you, sir.
Thank you, Ellen. Thank you very much for inviting me to chair this session on refractive cataract surgery. And good evening, everybody. And it is my pleasure to invite my co-chair, Dr. SPS Grewal from Chandigarh, who heads the Grewal Eye Institute. And Dr. Ellen Kumaran will be our moderator for this session. As all of you all know, modern cataract surgery is refractive surgery, and patients expect spectacle independence, at least for distance, but ideally for distance, intermediate, and near. So today we have some of the top speakers with us, and we are going to look at how all aspects of refractive cataract surgery, from assessment of the patient, preoperative assessment of the patient, biometry, and the importance of biometry, various IOLs which are available on the market, and also how to deal with postoperative surprises so that you can get a satisfied patient. So without further ado, I would like to introduce the first speaker of the session. The first speaker is Dr. Sheetal Brar. She is the senior consultant phaco-refractive surgery at Nethadama, and she will be talking on pre-op assessment for refractive cataract surgery.
A very good evening to one and all. At the outset, I would like to thank Dr. Ellen, KOS, as well as Dr. Sri Ganesh for inviting me to this exciting session. Today, I will be speaking about preoperative evaluation for presbyopic refractive surgery. I do not have any financial disclosures to make. We see quite frequently that our patients after cataract surgery have a very high expectation these days, and especially if they have undergone a multifocal or a premium IOL implant, they do not want to wear glasses for any purpose, and it is sometimes challenging to deal with these patients postoperatively if they do not achieve a perfect outcome. So it is very important to evaluate and assess and rule out some patients who probably will not be very happy after their surgery with any of the premium lenses. So the first investigation which I would want to stress here is the dry eye evaluation. So it has been found in different studies, and it's also published quite extensively, that the tear film or the ocular surface can affect the repeatability of keratometry readings, and it can increase the higher order aberrations, which can affect the biometry as well as the decision making regarding the type of lens that you would want to choose for this patient. So it is very important to evaluate the dry eye. Now we are shifting more towards non-invasive dry eye evaluation and tests, such as the SBM tear scope, which we have in Netradhama. So this helps us to assess the ocular surface, including tear film, through a combination of dry eye tests. It gives us information about every layer of the tears individually, and also does the calculation of tear meniscus and assesses the health of the meibomian glands. So this is a very useful tool. Also, you can use HD analyzer for tear film analysis, where you can see that the OSI will actually show how the health of the tear film is. In this particular patient, the OSI is very high, 11.37, and the tear film is very unhealthy and very unstable. So you can see this red zone and the spread of the tear film, the breakup of the tear film. After a treatment with the cyclosporin and dry eye medications, this ocular surface of this patient has improved quite significantly, and the mean OSI has reduced to 1.27, which is much more acceptable. And now you can go ahead with your biometric measurements much more confidently. Corneal topography, I would say, is the most important investigation that you should perform. It helps us to identify abnormal corneal shapes such as form fruste keratoconus, PMD, post-LASIK ectasia cases, post-RK cases, which can show extreme flattening and irregularity. For cases which need toric implants, it is good to do also a topography to verify the keratometry values and the steep axis of your toric lens. It also helps us to identify the astigmatism as a regular or an irregular one, wherein in the latter case, you would not want to perform any kind of premium eye surgery. So, topography also gives us information about corneal higher order abrasions. Usually, abrasions which are within 0.3 microns are considered to be ideal. However, up to 0.5 microns is acceptable, and anything more than 0.5 should be considered as a contraindication to multifocal technology, because this would denote an irregular cornea, and hence will not give you a very good quality of vision after the surgery. Now, many times we have such patients who had undergone refractive surgery many decades ago, and now they come for refractive for the cataract surgery. They do not want to still wear glasses for reading purpose, and hence want a multifocal implant in their eyes. So for these cases, the holiday e-care report generated in the Pentacam comes very handy, wherein you can see this pattern, the holiday e-care distribution. In an ideal scenario, this should follow a Gaussian distribution, and this should be like a single peak, as in this particular case of post-smile surgery. And the higher order abrasions also are not very high. It's 0.2, which is acceptable. And this particular patient, if is very keen on multifocal IO technology, can be counseled for the same. On the other hand, we have this case of post-RK, where you can see an extreme flattening in the center and a very irregular cornea. And the distribution of the keratometry does not follow a Gaussian distribution. And the graph is very much skewed to one side. You can also see very high corneal abrasions of 0.8 microns in this case, which is quite high and is thus not suitable. In any cases, those have an unhealthy endothelium definitely should not be counseled for a multifocal implant. Now, increasingly, the concept of angle kappa and alpha is gaining popularity in pre-op evaluation of multifocal lenses. The angle alpha is the difference between the center of the limbus and visual axis, and angle kappa is the difference between the center of the pupil and visual axis. Now, in an ideal scenario, the lens should be centered on the visual axis and on the pupillary axis. All of these should coincide to get a perfect post-op result and good quality of vision. So you can also use ray tracing to evaluate angle kappa and alpha. Usually a value within 0.6 millimeters for angle alpha and angle kappa within 0.5 millimeters is considered to be normal. So these values are also available in your IUL Master 700. So which of the two is more important? Now, since the lenses have a tendency to settle in the center of the capsular bag, generally the angle alpha is considered to be more important in this circumstance. So on the basis of angle alpha values, you can decide on the type of IOL also. Within 0.4 4 millimeters, if the value is, you can use a low ad multifocal or a trifocal IOL. If the value is within 0.4 to 0.6, an EDOF lens, which has a central optical zone slightly larger, can be preferred. And if for a value anything more than 0.6 millimeters, usually a monofocal IOL will be a better option. Any of these pathologies such as vitreomacular traction, epiretinal membrane, posterior staphyloma, choroidal neovascular membrane, etc., would certainly compromise on the postoperative results and quality of vision. And these cases should be directly ruled out for multifocal technologies. Now, having a good biometer, which can give you a very predictable axial length and keratometry values, is an extremely important tool for in the armamentarium of a cataract refractive surgeon. IOL Master 700 is one of the most advanced biometers that we have available today. It has many more keratometric points compared to IOL Master 500. And it is also equipped with swept source OCT for axial length measurements as compared to the laser interferometry in the IOL Master 500, and hence gives you much more predictable and accurate values. It also now has the total keratometry, which is a concept based on the scans taken using the telecentric 3-zone keratometry and the swept source OCT scans, which generate a toric model of the cornea and does the actual calculation and measurement of the posterior corneal surface. So this concept is more important in those cases where the cornea has been modified, where you need to know the posterior curvature values such as toric IOL implants and post-refractive surgery cases. Preoperative counseling, I think it forms a major component of the whole planning and evaluation of a multifocal IOL candidate. And this should be done extensively, and each patient should be counseled about what they can expect from the surgery. Each patient's individual lifestyle and needs should be understood, and accordingly they should be counseled. They should also be informed about the potential side effects of these technologies such as dysphotopsia, etc., and the future need for enhancements. It may also be important and helpful to score the patient on his personality using one of these questionnaires which are available. We use the updated DEL questionnaire, which is a set of some leading questions which can be asked to the patient, and it can help us to assess the personality of the patient, his expectation, his tolerance to the side effects of the technologies, and also whether the patient would be willing to use glasses or not. So all this can be assessed, and this can help you a lot in deciding the patient's candidature for a premium IOL implant, and can also help you to avoid dissatisfaction after the procedure. So in conclusion, detailed preoperative screening, proper counseling, as well as meticulous surgery and postoperative care, all these form important components of a premium IOL practice, and following these you can generate happy patients and also grow as a successful premium IOL practitioner. So thank you so much for your kind attention, and if there are any questions, I'll be happy to take them. Thank you.
Thank you, Dr. Sheetal, for elaborating the preoperative assessment for premium IOLs. If there are any questions from the audience, we can just have a 2-minute discussion on on each topic before moving on to the next speaker. So I think many of them do not do any of the panelists who want to kind of contribute.
Yeah, so Dr. Sheetal, that was a great talk. I mean, you explained very beautifully. Everything was very lucid, and you know. But the one thing that I realized personally for me, I realized that with these newer lenses, like you said, with the new trifocals and EDOF, this angle alpha is now playing a little role compared to what probably it would have been playing with the older generation, you know, bifocal, multifocal lenses. So while I'm looking at it.
Most of these new lenses, even the trifocals, their central zone is larger. So if you look at the panoptics, panoptics, even though it's a trifocal lens, but central zone is larger compared to the other trifocals. So a little bit of decentration actually would not really make much difference clinically. I think we can do a study and then look at patient outcomes and the satisfaction.
Also, all Indians know we are mesopic pupils are only not that big.
Pupils
so
are
we
also
lucky.
small. That's right. Yeah. So do you believe in how do you assess patient's personality? How do you decide what lens for the patient?
So actually, that's a very great question. And initial years of my practice, my biggest problem was where to pitch and what to pitch to the patient. But these days, depending on their preoperative investigations, if they are suitable for a multifocal lens, I advise it to every patient. 100% patients who are suitable for any sort of premium IOL, I advise them all. And I have stopped discussing, I guess with most practices, I don't discuss the finance of it. So that gives me time, they give them time to understand the science of the product rather than looking at the monetary aspect of it.
I think it may also be useful to, when you're giving them this question, because we use the DEL quite commonly for all the multifocal patients. I also started giving the question and asking them to read it, because with that, if you ask them directly, okay, how much do you read? Where do you keep? Sometimes, they're not. But if you just casually give them a book or the questionnaire and just ask them to read, so you can yourself assess what their reading distance is, and accordingly also that can give you an idea. You want to give them a multifocal of a higher ad or something which is more good for intermediate. So casually, I think you can get a lot of information about the patient, his needs, when you talk to the patient itself. So during the conversation in a casual way.
I think that's a great point. Just give a newspaper or something to read and see how they work with it.
Yeah.
And I think assessing the what the patient's expectations are for reading, for intermediate, for the distance vision is important, because you have different lenses which have different intermediate distances, and some of them are much taller with longer arm lengths. Some of them are shorter. The myopes are used to keeping reading material closer. So depending upon the refractive status, depending upon their height, length of limbs, these are also things that can be assessed. And of course, pupil size also, I think, needs to be considered, because some of the lenses have variable distribution of light depending upon the pupil size. So these are also things that can be looked into. But I think otherwise, I think you did a very good job in going through all the preoperative tests, and many of them actually ignore the dry eye assessment, which is very important, because you can have almost 2 to 3 diopters difference in keratometry when you have dry eye, and this will completely skew your results, because for the multifocal or trifocal technology, you have to be within quarter of a diopter for sphere and within half a diopter of SIL to get good results. So let's go on to the next topic, which is biometry. And it is my pleasure to introduce Dr. Shreyas Ramurthy, young dynamic surgeon from Coimbatore, who's going to speak on newer biometric formula and devices for perfect outcomes.
Good evening, one and all. At the outset, I would like to thank Dr. Ilan Kumaran and everyone at Karnataka Ophthalmic Society for giving me this kind opportunity. Today, I'm going to be talking to you all about newer biometric formulae and the devices, the newer optical biometers that we have today to perfect outcomes. So the formulae, as we all know, have evolved over times, and right from the first generation theoretical formulae, moving on to the regression formulae, and then the fourth and now the fifth generation formulae are what are currently in vogue. Now, what really differentiates these formulae? Now, while key reading and axial length was the cornerstone of all the older formulae, the effective lens position is what separates the newer ones from the older ones. Now, why does effective lens position become important? The ELP, or the effective lens position, is the predictive position of where the final IOL is going to rest in. And this cannot be measured directly, and it has to be calculated by the formulae. And this is where the newer formulae differentiate themselves. Now, why is ELP important? It's primarily because of this, because it's only in 73% of eyes where the dictum that we follow expecting that long eyes will have a larger AC depth and short eyes will have a shorter AC depth is actually followed. In the remaining 24% of these patients, that ratio is not maintained. And as a result, the final resting position of the IOL will also vary. The fourth generation formulae, like the Holiday 2 and the Haigis, involved a lot of newer parameters apart from our axial length and keratometry, like age, preoperative refractive error, the white to white or the corneal diameter, the preoperative AC depth, and the lens thickness. The Haigis also brought in 3 other constants which need to be used in the formulae, and both these did go a long way in improving the outcomes. But what we have now moved on to is the formulae which we call the 5th generation formulae, which includes the Olsen, the Barrett Universal 2, and the Hill RBF. And I will briefly detail upon each of these formulae. The Olsen formula is based on ray tracing, and it really has improved the way the ELP is predicted. It uses what we call as the C constant. The C constant is essentially the ratio of the lens thickness to finally where the resting position of the IOL is going to be. So for example, if the C constant is around 0.5, that means the IOL position resting will be exactly in the middle of where the current crystalline lens is. And based on this calculation of C constant using ray tracing technology, this has helped in enhancing outcomes. The Barrett Universal 2 is a thick lens formula. Apart from the regular parameters, it also takes into account the AC depth, the lens thickness, and white to white. And more importantly, it incorporates something called the lens factor. It's especially useful when we move on to high myopia, wherein, let's say, below -6, where the lens design changes from a biconvex to meniscus, wherein because of the principal plane of the way the haptics will be positioned, the final optic position might be a little higher or lower. And this is also incorporated into these formula, making it extremely accurate even for those very high myopic eyes. The Barrett Universal 2 is now available online and can be accessed by any one of us. And these are the standard measurements that we need to enter into this formula. Apart from the axial length and keratometry, you have the lens thickness and white to white, which are optional and that can also be entered. For post-LASIK eyes and post-RK eyes, you also have the Barrett True-K, which has become extremely useful. You also have the toric calculator, the Barrett toric calculator, as well as the Barrett True-K toric calculator, which have become invaluable in patients who are requiring toric IOL surgery in post-LASIK patients. There is also this integrated K calculator, wherein you can use data from 3 different instruments and input each of these instruments, thereby reducing the inter-observer and repeatability issues of these instruments themselves. Coming on to the Hill RBF, or the Hill radial basis function, it essentially uses artificial intelligence and pattern recognition. The RBF is essentially taken from a large Lenstar based data, which uses this pattern recognition. And this is now independent of the Virgin's formulae and therefore does not have the limitations of any of the Virgin's formulae. And also, it does not require knowledge of ELP. So what it really does is it is data driven based on AI. There is adaptive learning, and it is self-organizing model. And this has been continuously evolving as more and more data is being fed into this AI model. And it is free of any calculation bias that we may have. Now, the boundaries itself, initially it was only limited between +6 to +30, and anything in very high myopic or high hyperopic range was given as out of bounds, and more data was calculated. Subsequently, this now has become widely available both in rbfcalculator.com as well as in ASCRS website. And these are the basic data that you need to enter into it. Now we have, after the initial version, you have the version 2 and version 3 of the Hill RBF, which has come in, where the data has been expanded, more number of cases has been included. Now it provides a wider range from +6 to +34 for the biconvex, and for the very high myopic from +5D to -5 diopter lenses. So it's really a very small fraction of patients who will not be who will be out of bounds in the newer version of the Hill RBF. Additionally, from the previous 4 parameters, it also takes into account the lens thickness, white to white, CCT, and gender And these 4 parameters have added to the accuracy of this artificial intelligence model. So essentially, to sum up, while initially we were following different formulae for different axial lengths, like Hoffa-Q for short eyes and SRKT for long eyes, nowadays we are moving on to using a single formula like a Barrett 2 or a Hill RBF for all ranges of axial lengths. And it is these universal formulae that we are applying for all axial lengths. To aid with the newer formulae comes better measurements with newer optical biometers, and that has really paved the way in improving outcomes. You have the newer IOLMaster 700, which is a swept source biometry, which is an improvement from the earlier partial coherence interferometry. The IOLMaster 500 in comparison with LensStar 900 did not provide corneal thickness and lens thickness, and that has been improved in the newer versions. Apart from the IOLMaster 700, which uses swept source OCT, you also have Tommy and certain other companies which use swept source OCT. But due to paucity of time, I'll just stick to discussion on IOLMaster 700. And essentially, this is a true B-scan biometry. It gives us a cross-sectional view of the eye. You get idea of the corneal thickness, the lens thickness, the ability to image the fovea, which is extremely important and enables us to know whether the patient is fixating properly or not. Before that, we had to depend on the patient cooperation for identifying fixation, but whereas now we can image the fovea. Just an example for why good imaging of the foveal pit is necessary. It makes sure that you have very repeatable measurements, which results in very repeatable calculations of IOL power. But in case the foveal pit is not imaged properly, just to give you an idea of a small difference in keratometry and axial length, but this can result in almost a diopter of difference when it comes to the IOL power calculation. So imaging the fovea is extremely important. Also helps us in detecting certain decentered fixations, which looks at the slight tilt of the images here. And this can also be rectified. You can also ensure certain simple macular pathologies can be identified, and the patient can be further subjected to a more detailed retinal examination. Helps us measure anterior chep depth ACD measurements, both in preoperative as well as in the pseudophakic eye, which was not very accurate in the earlier versions of the IOLMaster. This has definitely helped in improving the refractive outcomes, greater repeatability and reliability. The IOLMaster 700 showed fewer dropouts as compared to the IOLMaster 500. And also there was greater and more effective penetration even in dense posterior subcapsular and dense nuclear brown nuclear cataracts. And this has really been the collective experience that all of us have had. When it comes to, apart from the axial length measurements, keratometry is also very repeatable in both these devices, IOLMaster as well as LensStar. The IOLMaster uses just 6 hexagonal pattern. The LensStar uses 2 circles. It has a greater data point and 2 diameters, 1.65 and 2.3. The IOLMaster also employs something called the telecentric keratometry, wherein essentially the distance between these spots is maintained even if there is a certain blur in the image. So even if there is the observer is not very good or the patient cooperation is a little poor, still you get repeatable measurements, and that's the advantage. Quickly moving on to total keratometry. This is really what has been a game changer as far as IOL power calculation measurement is concerned. And here it really provides us a posterior torus fit. And basically whatever data points is being measured on the anterior cornea is now transferred onto the posterior cornea as well. And we get corresponding data measurements on the posterior cornea as well. This enables us to get both the anterior keratometry, the posterior keratometry, and then what we call the total keratometry. This total keratometry is ULIP compatible, and there is a specifically designed formula for the Barrett TK, wherein the Barrett formula using the total keratometry and is specifically designed for this. Earlier, when we were using toric calculators, using direct measurement values of the posterior corneal astigmatism from Pentacam or Galilei proved to be worse than the mathematically derived values of the Barrett or Baylor nomogram. But with the TK, there has been a paradigm shift wherein you're really using a specifically designed Barrett TK toric formula for these, using the posterior corneal measurements as well. And this has really greatly enhanced the results, as you can see in this particular graph. You also have the Barrett TrueK TK for post laser refractive patients, And this is also performed better than what we are currently using, the Barrett 2K or the ASCRS average or the Sharma's formula. The Haigis TK, which is also based on the total keratometry, was comparable to that of the Barrett TK. And this shows that using the total keratometry is definitely a step in the right direction. Apart from that, you have the angle alpha and the angle kappa measurements, which can also be done using this device. So to sum up, definitely using these swept source OCT with better penetration and the total keratometry with specifically designed Barrett TK and Haigis TK formulas has really helped us move in the right direction. So with excellent imaging and 5th generation IOL power formulae, emetropia for all has really become a possibility for each and every patient of ours. Thank you so much for your kind attention. I once again thank Dr. Elan Kumaran for including me.
Thank you, Shreyas, for elucidating the various points in biometry. Of course, most important is to have a good device, and then secondly, the formulae. Of course, the other advantage of telecentric keratometry is that, of the foveal imaging, is that you're sure that your keratometry is very repeatable. Because if you see the foveal pit, then the repeatability of the keratometry is very good. So that's another aspect to the IOL Master 700. And now they have the IOL Master 700 CT. And we have upgraded all our IOL Master 700s where you have corneal topography. So it gives you the central 4 millimeter topography. So you can rule out any irregular astigmatism. Or if you have any doubt, then you can subject the patient to a regular topography, and then you can pick up early keratoconus or irregular astigmatism with that. So that's also an additional advantage of the IOL Master 700. But excellent talk, and thank you for bringing out all these points. But if you want to tell the audience, if they have, because nowadays there's so many formulae, you have Kane, Evo, Barrett, Haigis. So what is the ideal formula? It's one stop would probably be the Barrett, because that's what we use.
Yes.
And I think the Barrett suite would fit in most eyes and most axial lengths, and unless, of course, it's very extreme. And we have been getting excellent results with this. Of course, the TK True K is not available on the IOL Master 700 as yet, but you can go to the APA-CRS website. Online. For those who don't have the IOL Master, it's freely available on the APA-CRS website. So you can go and use all the Barrett formulas. And this will definitely help you in achieving emetropia.
Yes, we follow the same thing, sir. That is, all our patients are just subject to the Barrett formula, and that's the universal formula or go-to formula for almost all subset of patients nowadays. And even in centers, smaller centers where we don't have an optical biometer, we just use the, change to the ultrasound constant on the online formula and then go ahead and use it. That's just one thing which you have to keep in mind, just in case you're not using an optical biometer in a smaller center. But otherwise, I think, I completely agree with your statements. And I think the limitation of doing a recorded talk is, I was repeating quite a bit of things which Sheetal had already mentioned, but I couldn't help it.
Shreyas, great talk. I just had a question. What is the minimum corneal astigmatism you would want to treat with toric lens, especially when you're going with multifocal? Is the limit different for monofocal and multifocal? And are you using TK for all cases, irrespective of whether it's a monofocal? Or like, do you calculate for toric for all patients or not?
Yes. So I think both are kind of interrelated questions. So the cutoff, yes, we are a little more sensitive for multifocal patients. 0.75 diopter is the cutoff for, especially against the rule astigmatism of 0.75. Maybe with the rule, we'll relax up to 1 or 1.25 at the most. Or maybe if we are combining it with a laser cataract, maybe a small arcuate keratotomy for patients with a low astigmatism can be considered. But for most patients, the most predictable way would be to correct them, especially a premium lens like a multifocal lens, to go ahead with a toric multifocal. We even go to the extent of saying, if they're not willing to choose a toric multifocal, let's say for the reasons of cost or other things, we either switch them to an Indian toric multifocal or tell them, please go ahead with a toric monofocal. but definitely not a plain multifocal if they have astigmatism more than a diopter. Again, one diopter against rule and 1.25 with the rule is our dictum, even for monofocal. 0.75 we do. I mean, maybe the T2 is one thing we go easy on, but anything T3 and above, we definitely counsel the patients for a toric. And at this juncture, I would like to say that the Indian torics like from Biotech, IOCare are also working extremely well. So really, I mean, I'm sure it's not a problem in Bangalore, but for tier 2, tier 3 cities where cost can be a concern, I think we should really go ahead and switch to even these Indian torics whenever the patient is not able to afford, and they give excellent results. And to answer the next question, which is whether we subject all the patients to a toric calculator, absolutely, and especially in premium lenses, but even all other patients as well. And it'd be quite surprising to see that what you would normally consider as a very low diopter cylinder on just a casual glance through the keratometry would require a T3 or a T4. And it's very important that we address all these astigmatism for optimal outcomes in these patients.
Yeah, I think that's a very important point, because you should always calculate for a toric. Many a times, if you just look at the anterior keratometry, you may feel that, okay, there's not much of corneal astigmatism. But actually, when you're calculating with the TK, you're looking at the posterior curvature also, and then sometimes a toric may be required. There are some patients who don't have significant anterocorneal astigmatism, but when you subject them to a toric calculation, it shows that they may require a toric lens. So we always calculate for toric, and in a premium IOL like a multifocal, your cylinder has to be within half a diopter. And so if it's like within one diopter, then we kind of we would also use the femto for relaxing incisions to bring it down to within half a diopter. But if it's more than one diopter, definitely we would go on with the toric lens, toric multifocal. And like you said, it's not about Indian and imported. In fact, some of the Indian lenses, I feel that the results for toric are actually better than some of the imported brands. The incidence of rotation also is less. We have done studies, and now we don't bring up this stability and rotational stability. So we don't bring up this Indian imported. It's just that yes, you need a toric or a monofocal. So this is something, and like I would say, the quality is as good.
Yes,
so
absolutely.
I think more people should.
Yes, sir.
In
No,
fact,
I mean, it's just
Ganesh,
that the confidence has increased, and I'm sure it's the same in your center as well. The toric volumes have gone up ever since we started using the IOLmaster 700 across the group, because it's in your face. You see the TK value, the posterior keratometry is available. So as soon as you open the biometry, even before you talk to the patient, you're able to see that the cylinder is significant, which is not the case earlier. And that's definitely increased the adaptation of toric IOLs in a much larger extent. Sorry, sir, you were saying something.
I was just mentioning, hi, everybody. Sorry, I joined a little late. And, I think amazing talk, but what Sri Ganesh was saying, that management of astigmatism, I think 70% of our patients now, we manage astigmatism either with a toric lens or with a small LRI. So I think managing astigmatism has come a long way and so predictable now. I don't have the 700 right now, but even without that and without TK, and, probably lots of us, I think 90% of our audience would not have the 700, but even without it, with a good optical biometer and using the, Barrett's nomogram, you can still correct very small astigmatism very effectively. And I think we should do a toric calculation for all patients anyway, and address it even for very small astigmatism.
Thank you, Shreyas. And I think we have a slight change in the order of talks, because
I had to request.
Gaurav has a request. Today is his wedding anniversary, and his wife is waiting for him to take her out for dinner. So congratulations, Gaurav.
Thank you so much. I'm so sorry to break order, but I had to request because I thought I'll just So can I go?
At least allowed you to present, sir.
Thank you so much.
And with Samaresh's permission, I would ask Gaurav.
You have all my permission, sir.
Thanks, Samaresh. Thank you, everybody. Yeah, thanks.
Managing refractive surprises post-op for better patient satisfaction.
So I think this topic should have been more appropriately at the end of the presentations, but I'll try to do justice to that. And so what is a refractive surprise? And, surprisingly, times have changed. I was speaking on this in AIOS in 2013, and ever since I've spoken 4 or 5 times. I hope my slides are visible and I'm audible clearly.
Yes, sir. Visible.
Yes, go ahead.
Yeah,
Go ahead.
okay, thanks. Yeah, you always have this doubt when you start presenting. Anyway, thanks. So, and I just saw and I was seeing my slides, how they have changed in the last 7-8 years itself. My slide in 2013 was showing that any refractive surprise is something beyond 0.75 to 1 diopter, and that time we did not even speak about toric surprises, frankly. But today, I think a refractive surprise, as we understand, is a failure to achieve the intended post-operative refractive target, which has completely changed over the years, as we were just talking in the previous talk with Shreyas. So today, I would, even this probably is a little kind of liberal. A residual refraction of more than 0.5 spherical, or even an astigmatism of more than 0.5 cylinder may be considered a refractive surprise today, depending on the patient and what kind of surgery you are performing for the patient and what is the expectation of the patient, frankly. And the threshold is probably even much lower for multifocal IOs, where even small refractive errors can be taken as a refractive surprise. And if a patient does not read 6.6 today, you have to kind of think why this patient is not actually. So 90% of our patients are usually within plus minus 0.5 and are 6.6 parts, or even 6.9, and you have to be prepared to deal with a refractive surprise when something like that happens. So problems with refractive surprises can, of course, be with a big surprise anisometropia, and a dominant switch can be very difficult to handle, because if the dominant eye ends up with the weaker uncorrected vision, and patients have a sense of failure, especially if they've not been counseled or prepared for a possibility of a refractive surprise, then we kind of overpromise and sometimes end up under delivering. So that's a problem. Predisposing factors for refractive surprises would be small hyperopic eyes, very high myopic eyes, eyes with very steep or very flat cornea. So basically outliers, and shallow anterior chamber depths, very shallow chamber depth, because the ELP would change. Any prior history of refractive surgery, especially an RK operated eye, because that is more likely to deliver a refractive surprise. Previous VR surgery can alter a lot of things and can be more predisposed, especially if they are silicone oil filled eyes. You can, and if you overlooked biometry or not been as careful as you can, and even when you've been extremely careful, you could still end up with a refractive surprise. And then, of course, eyes which may be missed, suspect corneas or ectasias, where you may end up putting a toric lens, not realizing that. So a topography here would be very useful to preempt a refractive surprise. And peripheral corneal syndromes, where the peripheral cornea is not healthy. And of course, sometimes dry eyes and contact lens use, these are all predisposing factors, and we all understand these today, and we try to address all of them. But knowing them is always good when you're planning a surgery, so that you can preempt a refractive surprise. And I also feel that setting the right expectations is very, very important for all our patients today. And I always tell patients that even with the, sometimes they ask that, will I have to not wear glasses if I'm putting like a trifocal lens with laser cataract surgery and everything? I tell them that even with the most expensive lens or the most expensive surgery, you may end up, you will never end up having a PAR which is exactly 0. You may end up with a small little PAR, and for which glasses remain. But for more than 90-95% of your activities, you will not need glasses. And very rarely, if we do have a surprise, we can always tackle it. And I think special at-risk eyes need special counseling, like the operated RK eyes or some other eyes where you're getting uncertain. For example, with the Hill RPF, as Shreyas mentioned, you can have out-of-bound eyes, and we've seen that they are more likely to have refractive surprises. So that's a very good thing out of the formula. Although we use Barrett's for mostly everything, but for those occasional eyes which come out of bounds on Hill RPF, we always counsel patients that they are likely to have a possibility of refractive surprise. So going on, I think once you know that you have, you can have a refractive surprise, you can plan for the unplanned. And why we have very few refractive surprises today is because of what Shreyas just spoke about, advances in optical biometry, newer formulas, which are much, much better at predicting, and better understanding of at-risk eyes, and better ways to deal with them. So I think the decision-making on handling refractive surprises basically depends upon how soon you detect it. So I think important thing is to pick up the refractive surprise early. So I think important thing is that we always, have to look at our patients post-op day 1. I frankly, even if I'm not seeing all my post-op day 1 patients, I get all their post-op slips, the moment I reach the hospital. Some of them I will see and some of them have been seen by other consultants. I will quickly go through all those 10, 12 eyes which I operated the previous day to see how their outcome was, their auto-ref is there, and their IOPs and stuff. So I think monitoring our post-op results. We also do a toric check for all patients. Basically, on the day 1, I think eye trace is not very predictable. So we put a single drop of cycloplegia of a dilator and look at the toric positioning on day 1. And then on day 15, we do an eye trace to pick up any, toric surprises. And that's the best time to kind of deal with them within the first 10, 15 days is the time when you can deal with the toric surprises. So those on day 1 where you feel that there is a doubt of a refractive surprise, you can call them up sooner than other patients whom you might call up, say, at 2 weeks, because if there is a refractive surprise, you might want to deal with it sooner than later. And I think toric IOLs need special attention. So once we have a refractive surprise, where do we begin? Most important thing is to talk to the patient about it, and it should not feel guilty about it, but then you have to deal with it. So you have to tell the patient upfront that you may be having a small difference in IL power, and that's not something that we've done wrong. It can happen in small percentage of patients, and then of course reassure them that you'll be able to handle them really well, and patient will not have. So once you are upfront about it, then dealing with it later becomes much easier rather than kind of ignoring it and pushing it under the carpet. So once you have that stage of the decision making, what's important is to then see if once you have a refractive surprise, look at the fellow eye. Is it a myopic eye, a hyperopic eye? Does it have a cataract? Because and especially if the eye in which there is a refractive surprise, if patient had a dense cataract before, he may not be so much uncomfortable with it than a patient who already had a 6/12 or 6/9 vision when you did the cataract surgery. Also, whether it's a myopic or a hyperopic surprise, whether it's a small little surprise or it's a significant surprise, whether it's a spherical surprise itself or it's a toric surprise, whether you were attempting a toric IOL or not attempting a toric IOL. Also, whether it was a monofocal IOL which was planned or it's a multifocal where the tolerance will be much lower. So you have to prepare yourself. And how symptomatic is the patient? One patient with a small surprise may be very symptomatic and want to kind of eat your head completely. And another patient, even with a significant surprise of say -1 or something, may not be so uncomfortable about it and may have a lower threshold to complain. So all that will go into trying to help this patient. And you have to then reassure and make sure that you manage it appropriately. So why this slide? First one is, when you have a surprise, sometimes it is a capsular block syndrome and one should always look out for it. You can always pick it up on the slit lamp because you will see that pooling in front of the posterior capsule and behind the optic. And these are fairly easy to manage. Now, going on, I think we all understand that there are obviously so many ways that we can handle refractive surprises, and that's what this talk is all about. So first thing, of course, if you're planning not to intervene immediately, offer the patient some small classes, and you'll be surprised that small surprises, sometimes these patients don't want an intervention later on. For example, if it's like a 0.5 or something, and initially the patient might complain, sometimes in a month when you call them back, they would have accepted the situation and dealing with it, and they would not want an intervention at all, which makes it much safer for the patient as well. But this is the principle. Hyperopia up to 1 diopters, you could actually do an optic capture and change the ELP of the lens. If it's a hyperopia from 1 to 3 diopters, or if it's a myopia up to 8 diopters, astigmatism up to 5 diopters, and the time is up to 1 month, then you can go for an IOL exchange, because early IOL exchange is one possibility. If it's more than 3 months, then you can easily correct these with laser refractive surgery, and that works best if you are yourself a LASIK surgeon, or you can take the help of a colleague. And if hyperopia is greater than 3 diopters and myopia greater than 8 and astigmatism greater than 5, then IOL exchange definitely becomes a much better option. And later, if it's much longer, then you can go in for a piggyback implant, which have come a long way today. So I think what is important to understand here is early IOL exchange or repositioning can be done if you have by mistake used a wrong IOL power completely, or if you've dealt with a significant refractive error and picked it up soon, then you might as well want to do an IOL exchange, because even techniques of IOL exchange have become very, very good. The instrumentation is so good now that you can actually go from small incisions and explant and implant a new lens, and it does not really alter the visual outcome or the astigmatism of the patient. Again, if you have a high hyperopic error, which is not amenable to a good laser correction, you might want to do an IOL exchange very soon. And also a very high astigmatism, which you might not want to deal with later on and rather correct it right there. So I think rotation is fairly simple today. Toric IOLs, if done within the first 15 days or so, it's usually not difficult. But even sometimes I've done it at about 3 to 4 weeks. And if with hydrophobic lenses, of course, the adhesions form much faster, but you have to be, early to catch these and not keep delaying it with wishful thinking that the patient will settle down and intervene early. I think the eye trace is a very good tool for those who have it for judging how much is the toric check, and if you have a surprise, how much you might want to rotate. But for those who don't have one, it may be easier to go to the astigmatismfix.com, which again gives you very good idea of how you might want to reposition your lens or exchange the lens. Both can be very easily done. And this helps us for our toric IOLs. I think I'll skip this video because we'll run out of time and everybody knows how to rotate a toric IOL. Important thing is to know that you can kind of go under the capsule and do a visco dissection and ease out the lens and make sure that the haptics are freed, because they are the ones which usually get caught in the periphery of the capsular bag. The other formula which I think I really enjoy for these situations is what Shreyas mentioned, is the Biarritz RX formula, which has options for IOL exchange and for piggyback IOL calculations. And I use this now preferably for my situations where I might want to do one of these two things. And it kind of, once you populate all the data and choose the lens implant, it gives you a very good idea about whether you should be exchanging the lens, or you can also make a plan for a piggyback lens. And this is easily available online on the APSRS website. And once coming on to piggyback IOLs, I think we've a lot of advancements with the Indian lens and the Sulcoflex, which is available from the imported ones, and they have their own calculation formulas. So you can use one of these, and they have a whole variety of lenses available to fix in the sulcus. It could be a toric, it could be an aspheric, it could be multifocals and multifocal torics, and you can get customized lenses made as well. And here I was one patient whom I had operated as a pediatric and a short video, pediatric surgery done, cataract surgery done almost 15 years back. Now this guy is a doctor himself, and he wanted a correction for his eye, which had a high refractive error. And in the fellow eye, he's phakic, and he sees very well with the fellow eye. So we decided to go with a customized toric multifocal piggyback lens implant. So this was not really a refractive surprise, but it's a long-term refractive surprise where patient later on goes on to progress, and you can use one of these lenses, and they go in really well and fix. And the outcomes are really, really good with these. So this was a trifocal toric implant. Going on, I think I'll try to finish off. Laser procedures, I think, are the mainstay for people who themselves do laser corrections, because most often those people who don't will not end up referring those patients. So it also depends a lot on the patient surgeon's comfort zone, whether he would perform refractive surgery himself. If he does, then they will always find it much easier to do a small touch-up on the laser correction, and it avoids the need for additional intraocular procedures. And you have a choice of doing on the surface or with a flap on LASIK, or even smile. We've done a couple of smiles on our post-op refractive surprise patients, and they do extremely well because the ocular surface is not touched at all. And however, if you have to make a flap, and especially if you have used to use a microkeratome, then you have to wait for wound stabilization to happen. And then for that, you have to wait for at least 3 to 6 months before you might want to use any kind of flap making procedure. Otherwise, you can always proceed with the surface once the refractive power is stabilized for the patient. And PRK, as I said, can be done at any time. Now, to finish off, I think situations not ideal for laser vision correction, very high refractive errors. ACIOs and iris claw lenses, when we were using microkeratomes, are again anathema. Large unstable incisions can be a problem if you're planning to do any flap-based procedure. And again, high hyperopic corrections or very high astigmatic corrections may not be great, and there a piggyback lens would be definitely better. Also, we can do late IOL exchanges for large refractive errors. Sometimes, you have a referred patient, pediatric cataract surgery done 15 years back, as I showed you. And also you have to look at the status of the posterior capsule when deciding whether you can go ahead with a late IOL exchange or with a piggyback or with a laser touch-up. And my last slide, special situations, RK operated eyes. Now, if you have a refractive surprise, because they're pretty common that you can get with an RKI, and you would not want to open these incisions for IOL explantation. So these are the situations where you also may not be able to do any kind of laser surgery. So they will be ideal for piggyback lenses. And I have 1 or 2 patients where we did a piggyback lens on a refractive surprise in an RK operated eye, and that was a much better procedure than anything else. Also, if it's not your patient, there the situation would change completely. So you would have to deal with that in a very different way than what you would deal with if it was your own patient. And you have to handle with kids gloves and not accuse the previous surgeon, because you don't know what circumstances were. Maybe it was a mature cataract, maybe it was something where surgeon was. So always be careful about not blaming your previous surgeon and handling it tactfully. Vitrectomized eyes also need special care. And ocular surface issues can also require you to be changing your decisions based on ocular surface issues. So I think it's a stack of cards, and you have to find the perfect balance and find the perfect thing. All these options are great options today. And for refractive surgeons, laser correction procedure may be good. For a cataract surgeon, it may be an IOL exchange or a piggyback lens. All these options are excellent methods to deal with refractive surprises today. And with that, I think I'll stop, and thank you for allowing me to speak, Shri, over there.
Thank you, Gaurav, for that excellent talk. Just one point, about re-rotating the toric IOLs. I generally wait for about 3 weeks because the astigmatism also kind of settles, and then the bag also is a little sticky, so it does not re-rotate. So,
Absolutely.
some of them like to take it up and rotate it early, but then because they're kind of afraid that the patient is not happy, and then they want to set it right immediately. But I generally like to wait for about 2 or 3 weeks and then do the rotation.
I agree
So that's
completely. Not in the first 10 days because, I would always do it after 10 days. Yes.
And the other point is, of course, for piggyback lenses, I use phakic IOLs, and they work very well. The Indian phakic IOLs are not very expensive, they're not as expensive as the Rayner lenses, especially for astigmatism. So they work quite well, and I've been using these, and so that's another thing that you can do. You can use a phakic IOL as a piggyback lens to correct any refractive surprise. Need not necessarily go in for the sulcus lenses. They may be more expensive and more difficult to get if you have a high cylinder or so. So I think we won't
I
hold
agree.
you.
I've been using the
Yeah.
IOC ones. They customize it, and they're not as expensive as the Rayner ones. And I have no financial interest, but I completely agree. That's another great indication for the phakic Indian phakic lenses.
So we won't hold you any further from your dinner. So congratulations once again.
Thank you
and our
so much.
team.
I'm so sorry for disrupting the whole program, but thank you everyone, and thanks Dr. Ilan and Dr. Sri Ganesh and all my co-speakers for inviting me and bearing with me.
Happy anniversary, Gaurav.
Thank you, Reval sir. Good evening, sir. Thank you so much. Thanks, Sheetal. Bye.
Enjoy
Bye.
your
Thanks,
evening.
Sandesh. Thank
Bye,
you.
bye.
Bye.
So it's my privilege to invite our next speaker for today, Dr. Samresh. I think everybody knows him. He's from Jaipur, and he's been doing some excellent work, and he'll be talking to us about astigmatism, managing astigmatism for perfect results, and toric lenses.
Thanks a lot, Dr. Sri Ganesh sir. It's it's nice to have you introduce me. You've always been a sort of a mentor and guide in all walks of life for me. I would like to thank the Karnataka Ophthalmic Society and Dr. Ilan Kumar for inviting me for this talk. Karnataka is very close to me because I graduated there, and I still, part of me still wants to come back to the same state all the time. So cataract surgery has undergone many milestone changes in the last few years. Where that we at our age have been very fortunate to only see the final outcome, but the biggest advantages being smaller incisions, more higher power calculations, more targeting emmetropia, as Shreyas has already discussed, and improvement in IOL materials. Astigmatism was overlooked for a large majority of evolution of cataract surgery, principally because we could not address it, or if we could, it was a little suboptimal. Although it was recognized early on and even later, a big study done by a group in Singapore said that almost about 60% people had some sort of astigmatism. This was one of the most common causes, untreated astigmatism, for suboptimal visual outcomes, and that would lead to consequences for the rest of their lives. If we look at astigmatism distribution, we should. It's very important to understand that majority of our patients lie in the low to moderate astigmatism group. So these higher astigmatic powers like the T5, T67 are not that commonly used in clinical practice. But the T3, T4, and now the T2, which is a low astigmatism correcting toric IOL, are the powers that are, at least in my hands, the most common powers that are used on a day-to-day clinical practice. And most of the people lie in this bracket. In our series, where we evaluated about close to 2,000 patients, we realized that like we had shown in that graph, a major chunk of people lie within 0.5 to 1.5 diopters. And very few, just about a quarter of the population lies within the 0.5 diopter, and again, very low in the higher astigmatism group also. So we wanted to understand that in our clinical practice at Raghudeep, does astigmatism matter? So we had two groups. We divided our patients into two groups. Group 1, which has less than 0.5 diopters of cylindrical correction, unaided, and group 2, which had more than 0.5 diopter cylinder. And we wanted to look at two things where it matters the most. One is contrast sensitivity, and second is reading vision. When we looked at contrast sensitivity in all conditions, photopic, mesopic, and mesopic with an induced glare using the vector vision chart, we realized that the group 1, which had low astigmatism, was significantly better than group 2, which had more than 0.5 diopters as astigmatism. But even after correcting that astigmatism, we saw that the group 1 was even better, even in mesopic conditions, even after putting that 0.5 or more diopter in group 2, which goes on to say that if you can clear anything at an IOL plane or at a corneal plane, it's going to be significantly better than correcting it at a spectacle plane. Again, same thing reflected even in reading vision, that the reading speed, reading acuity was better in the group 1 as compared to group 2, which had more than 0.5 diopters of cylinder. So cylinder matters. Even 0.5 diopters will matter when you're testing the performance of a patient in an IOL. But we need to understand that astigmatism consists of two things. It consists of what's existing in the eye, which is the pre-existing corneal astigmatism, and what you induce, which is your SIA. So when you do the math, again, by complex mathematics, most of our patients, more than half of our patients, will belong to a group which needs correction of astigmatism. Up until now, like Dr. Sheetal had brought about, and again Shreyas had brought about, anterior corneal astigmatism and surgically induced astigmatism was the limit of our knowledge. But then came the role of posterior corneal astigmatism. And that I think is a no-brainer, because once it gets incorporated into the neo formulas, most of us may not even have to buy machines that measure posterior cornea even now, but we can really get on target with good formulas. So of the many options that are there to treat corneal astigmatism, like clear corneal incisions, keratotomies, opposite limbal incisions and all that, in my hand, what I understand best and works favorably and in long term is a toric IOL. A toric IOL, because you're treating the problem right at its nodal point, and secondly, because it's fairly stable, and unlike a corneal incision, it may not regress with time. Toric IOLs have been there for a while. Shimizu et al. In 1994 suggested this for correction of astigmatism in cataract eyes. But why toric IOLs? Why? Number one, because it's a component of a routine cataract surgery. You're not doing anything extra. You're not even making an incision extra. You're not subjecting the patient to any other surgical maneuver. Astigmatism treatment with a toric IOL over the years has been shown to be extremely accurate and predictable. And like I said, there's no regression, because the IOL once in place will not really shift unless and until something gross happens. More importantly, if you don't like it, you can always remove this IOL and put back a monofocal IOL. Or if your axis is wrong, you can rotate it. So it can be reversed, it can be titrated, unlike other techniques. When we look at an IOL in today's date and time, in today's market, there are many companies. And like Dr. Sri Ganesh said, the Indian companies are doing exceptionally well as well. So it's not like the foreign companies or the imported lenses are only good. But when we look at a lens, we should look at the following things. One, it should be stable. Stable in the sense that it should be easy to implant. Its intraoperative performance should be good. But post-operatively, most importantly, it should not rotate. And in terms of long-term stability, I think we all know the material plays a really important role, and we want something that is biocompatible for a long term. Again, this is very simple. Spherical lenses have a cylindrical component over added to that to make a spherocylindrical lens. And at this point in time, it's very important to understand that bioadhesion, if it plays a role, it has to play a role in toric IOLs, because you want this IOL to stick to its place, fibrose in time, and stay there. So it should not rotate, it should not decenter. And it is shown that acrylic IOLs in human autopsy studies do much better than older IOLs like PMMAs or silicone IOLs, which are now not in fashion in any case. So choosing the right IOL may be a very good IOL platform, not only in terms of the toric stability, but also in terms of bioadhesion and biocompatibility, may be very important. Like is a fear in anybody's heart, there's also a fear in our heart whether these IOLs rotate. So our team back in 2009 did a study where they made a software at that point in time, because there was none available, to look at the post-operative rotation of toric intraocular lenses. And this was published in JCRS then. And we saw that the rotation was very, very less. And in each follow-up, maximum rotation was noted between 1 week to 1 month. And either it didn't rotate before or after 1 month, it sort of stabilizes because of bioadhesion. Again, this is how we did it. We made a software and we used major blood vessels on the patient's limbus or episclera to find out the centration of the IOL. And this is just another example. And this is to show you 1 month post-operatively. Exactly, we can superimpose. Now there are better softwares available for this. But at that point in time, this was the best one could do. We found out that with in our clinic, rotation could be measured in 0.1 degrees. This software was very easy to use. And median rotation was only 1.5 degrees, which in any case may be maybe even an error in implantation. And so these lenses were extremely favorable and extremely stable. this is again just to show you that rotational stability has been compared in many eyes and they've shown exactly the same thing. When it comes to mastering the toric IOL, it's very important to identify the type of astigmatism, determine surgical plan, pre-operative plan. You want to do a good topography, you want to do a good biometry, and you want to use an appropriate toric IOL calculator. And fortunately for us, now these are incorporated into the new biometry machines. So like Shreya said, it comes right on your face because you now know if you need a toric IOL. And so much so that I rely completely on the Barrett toric calculator that comes with my Lenstar, and I do not really cross-check it too much these days. And then the whole integrity of marking the IOL and aligning into axis is another talk in itself. But we need to understand that what we are treating is regular astigmatism. There is absolutely no point in discussing irregular astigmatism and toric IOL correction, because if your cornea is irregular, the astigmatism also has a component of higher order aberrations, which will cause scatter of light. And under no circumstance will you be able to see clear, even if you implant a toric IOL. So this is just our prospective interventional series, which we did on 100 patients with pre-existing corneal astigmatism. We looked at their uncorrected visual acuity on post-op day 1 and 3 months and rotational stability. And I'm just going to cut through this to say that uncorrected vision was achieved of better than 20/30 or 6/9 in 94%, which is close to almost a very good number at 3 months. And 85% of the eyes had a residual astigmatism of less than 0.5 diopters, just to show the IOLs are very stable and very predictable. And what you set out to achieve, you generally do. IOLs didn't rotate much, like we discussed. It was just 1.6 degrees at 6 months. And after that, it's unlikely to rotate at that point in time. So this is just a graph showing the same. I'm just going to run through this in the interest of time. Again, median rotation was only 1.1 to 1.6 degrees. So the key to success is to understand that each eye is different, and each eye has to be counseled individually. You may have a toric in one, you may have a non-toric in one, you may have a higher toric in one, but look at each eye differently and then look at the person as a whole. Also look at the person differently. You have to understand what the requirements are. And I got a beautiful tip from Dr. Sheetal in the previous talk, that you'll see how the patient talks, see how the patient holds their cell phones or how they hold a magazine or a newspaper by passing it on to them. They'll give you a lot of clues as to what they might accept. Again, amount and type of astigmatism is the key. So please be thorough in calculating your astigmatism using good machines, good biometers, and good topographies. For irregular astigmatism, stick to an aspheric IOL and use spectacles, correct that residual refraction with spectacles. Although every cataract patient in our clinic will demand immediate visual recovery and they want the moon for whatever they're paying, we must understand that miracles exist in fiction only. And in reality, one has to be very reasonable when we advise them. And despite the best surgical technique and despite the best IOL platform, sometimes some cylinders may remain, and that's only natural. Thank you.
Thank you, Samaresh, for that excellent talk. And I think we have to define what is clinically significant astigmatism. So clinically significant astigmatism, like you said, your study of looking at contrast between two sets of patients within half a diopter and more than half a diopter. So I think clinically significant astigmatism is anything 0.75 diopters and above. If it's less than 0.75, then it's not clinically significant. But for premium IOLs, I think the clinically significant astigmatism is 0.5 diopters. So the astigmatism, post-op astigmatism should be less than 0.5 diopters. If it's more than 0.5 diopters, it again worsens the contrast, because these lenses by themselves are reducing contrast. And if you have some amount of astigmatism added to it, then the contrast is worsened. So it's very important to correct astigmatism. And now with the newer formulae, especially taking into consideration the postercorneal astigmatism, it's made a big difference. I remember I started using toric IOLs when Alcon introduced it, and then there was no concept of postercorneal astigmatism. And I got so many surprises, more than 3/4 of a diopter residual astigmatism. We were promising patients that we're going to correct their astigmatism. And so I stopped using torics. For a number of years, I stopped using torics because I found that they're not accurate. And the reason was postercorneal astigmatism. And now with the formulas available today, I think you can be on target almost 95% of the time within half a diopter. So that's nice. I think we'll go on to the next speaker, that is myself. And let me just share my screen. So I'll be speaking on, are my slides visible?
Yes, sir. Visible.
Yeah. So I'll be speaking on modern trifocal lenses and our experience. I am a consultant to Carl Zeiss Meditech and Biotech. So today we have an array of multifocal intraocular lenses which are available, and you have actually a tough job choosing which one to use. They all offer spectacle independence, and they have turned cataract surgery into a potential cataract cum refractive surgery. But many of the older multifocal IOLs have some limiting factors. They have reduced contrast sensitivity, poor intermediate vision, and today most patients require good intermediate vision because they use cell phones, iPads, computers. Then the pupil dependency, especially the older lenses, which were refractive IOLs like the Array, which was introduced first. But now I think most of the lenses that are available are diffractive lenses. The expectations after modern cataract surgery are very high, and patients want quality of vision which they enjoyed before the aging process and enjoy life in all dimensions. They want to lead an active lifestyle without being troubled by glasses. And that's where the trifocal IOL technology comes into play. So these trifocal IOLs provide patients with an opportunity to experience a full range of vision from distance to near, and they utilize diffractive technology to split light energy into basically 3 focal points: near, intermediate, and far. If you look at the history of the trifocal lens, the fine vision IOL, the Physiol, was the first trifocal IOL which was available, and it was launched in 2010. More than a decade ago. And today you have a lot of commercially available trifocal IOLs, the Lisa, AT Lisa from Zeiss, the Acrisoft IQ Panoptics. Then you have some of the Indian companies, Optiflex Trio from Biotech, and then IOCare has the Acrydiff lens. Then you have the Fine Vision. And then you have Rayner also has introduced a trifocal lens, the Ray 1 trifocal, and I've used it and it's quite good. And there are also newer concepts of the trifocals like the Technis Synergy, which gives you better near vision. So let's look at some of these lenses and what they have to offer. The Zeiss AT Lisa Tree is a diffractive refractive IOL. It is a hydrophilic acrylic lens with hydrophobic surface. And it's got a negative spherical aberration of -0.18. It has 29 rings anteriorly on the entire optical surface, and it has a +1.66 add for intermediate, which focuses at 80 centimeters, and +3.33 diopters for near, which focuses at 40 centimeters. Light utilization is 85.7%, and the light distribution is 30% for near, 20% intermediate, and 50% for distance. And it has what is known as the LISA technology. LISA stands for L is for light distributed symmetrically, I is independence from pupil size, S is the SMP or smooth phase technology, and A is the aberration correcting optimized aspheric optic. So that's why they call it LISA. Then you have the Acrisoft IQ Panoptics, which is has an overall diameter of 13 millimeters with a 6 millimeter optic. The 6 mm optical zone consists of a central 4.5 mm diffractive area with 15 rings and an outer monofocal refractive rim. The 4.5 mm diffractive zone versus the full diffractive zone has some advantages. Greater light utilization, the light distribution is 25% for near, 25% for intermediate, and 50% for distance, which gives good visual acuity even with dilated pupils. So depending upon the pupil size, the light distribution varies in the panoptics, unlike the LISA, where it is independent of the pupil size. So if a patient is driving at night and the pupils are dilated, then there is better vision for distance. And if the pupil constricts when he's reading in good light, then you have better vision for near and intermediate. The anterior aspheric surface has a negative spherical aberration of 0.10, minus 0.10. And this is essentially a quadrifocal lens, but the fourth focal point is inaccessible. Instead, the light is diffracted for distance. And this increases the light efficiency, and there's a more natural transition between near, intermediate, and distance. It's got an addition of plus 2.17 for intermediate. So the intermediate is a little closer at 62 centimeters, and plus 3.25 add for near, which focuses at 42 centimeters. So this is basically the trifocal technology and the energy distribution of light for distance, intermediate, and near. This is the LISA at 80 centimeters for intermediate. But with the quadrifocal technology, you have distance, then you have a second point at 120 centimeters, then 60 centimeters and 40 centimeters. But the light distribution for at 120 centimeters is merged to the distance. And so you have basically distance 60 centimeters and 40 centimeters. The Optiflex Trio is a diffractive refractive lens, and it's designed with BLISS technology, which is brilliant light sensing, enabling optimal light utilization, and it gives excellent intermediate vision. It's got an optimized diffractive zone, minimal pupil dependency on any light condition, and it's hydrophobic acrylic with a yellow chromophobe, and this is available from Biotech. And we have used a few of these lenses. And we have done a study also, which I'll present later. It's got a spherical aberration of minus 0.20. It's got 12 rings on the anterior surface. And it's got a peripheral 2 mm clear zone. So the diffractive rings are in the central 4 millimeter. And the light utilization is 88.3%. So it's got a higher light utilization. And light distribution near is 28%, intermediate 27%, distance is 42. So most of these IOLs have a little bit of difference in the way the energy is distributed. Then you have the fine vision, which is a diffractive hydrophilic acrylic IOL with a spherical aberration of minus 0.11, 26 rings on the entire optic surface, and it's got an addition of 1.75 for intermediate at 75 centimeters and plus 3.5 for near, which is at 37.5 centimeters, a little closer for reading. The light utilization is 86%, and the distribution near 34%, intermediate 17%, and distance 49%. The Ray 1 trifocal is again a new lens. This is a preloaded lens from Rayner. It's a diffractive, fully preloaded hydrophilic acrylic IOL, and it's got anti-vault haptic technology. So you see this extra projection here. This gives rotational and central stability, and it's got neutral spherical aberration, 16 rings on the 4.5 mm anterior optic surface, and after that it is just a refractive surface. And the add is plus 1.75 for intermediate at 75 centimeters and plus 3.5, which gives you a near distance of 37.5 centimeters. The light utilization is quite high at 89%. Light distribution near is 26%, intermediate 22%, and distance is 52%. And this is the kind of, because of the difference in the light distribution, you can have difference in the performance and night vision and halos. With the LISA tree, you can have some amount of halos. The weakness, strength is the optical performance, weakness is halos. It's a plate haptic. Again, in myopic patients, if you're using a toric trifocal, you can have a higher incidence of rotation. It's also got hydrophilic, so PCO is more. The Alcon Panoptics, again, it's a C-loop platform, hydrophobic, which is an advantage, but the near performance is less. The Physiol lens, optical performance is one of the best with very low halo, but the disadvantage is hydrophilic lens. The Technis Synergy is again a new lens which is introduced by J&J Vision. It's a hybrid design of a multifocal and EDOF lens. They've combined a multifocal with the EDOF. So it is biconvex wavefront design, anterior aspheric surface, hydrophobic acrylic, powered by IntelliLight, an innovative combination of 3 proprietary technologies: high resolution HLED design, which is basically on the Symphony, an achromatic technology, and violet light filter. So what it does is it's like a 3.25 ad multifocal on which they have superimposed the symphony optics. So the symphony gives intermediate vision, the symphony optics, and then the multifocal 3.25 ad gives you distance and near. So it's got a 6 mm optical diameter, 13 mm overall diameter, 15 rings on the posterior diffractive surface. This is on the posterior surface. And it's got a frosted 360 degrees posterior square edge design. These are a few of the studies. There was a study comparing the visual outcomes between trifocal and the EDOF lens. That's basically the Panoptics and Symphony, and it showed that the results were comparable at distance and intermediate. However, the Panoptics have provided better near vision than the Symphony, which is expected. This is a comparative study between 3 lenses, the fine vision, AT LISA, and the Acris of Panoptics. And they found that all 3 of the lenses were excellent, uncorrected, and best corrected visual acuity for distance, intermediate, and near. The fine vision and Panoptics provided better intermediate vision than LISA tree, and the fine vision had better near vision compared to Panoptics and LISA, but patient satisfaction was good in all 3. So we did a clinical study to compare the results of LISA tree with the Optiflex trifocal IOL, and we had 25 patients. Outcomes were analyzed at 6 months post-op. And let me quickly go through this. You can see that eye seeing 20 or better, 6 or better, Optiflex trio 98%, AT LISA tree was 92%. So quite similar. Uncorrected near visual acuity at 40 centimeters. Eyes reading N6 or better, Optiflex trio was 98% and LISA tree was 96%. And this was the mean uncorrected intermediate vision at 70, 80, 90 centimeters. There was no significant difference between both the groups. We also looked at functional vision using the Salzburg reading test, which measured reading speeds. And all patients read more than 80 words per minute in both the groups. So it was similar. PCO development, of course, with the AT LISA, we had 2 eyes of 2 patients who had PCO and required yak capsulotomy. With the Optiflex trio, none of them, because it's a hydrophobic lens. Contrast sensitivity at 6 months was very similar. There was no significant difference between the 2 groups, and just the defocus curves again, which was similar. And you can show that you can see that it's got a nice functional vision up to 3 diopters. We also looked at dysphotopsia, glare halo, starburst, graded the dysphotopic phenomenon from 0 to 4, and assessment of spectacle independence. We found that the dysphotopia score was similar at 1 week. It was slightly higher at around 4.4. But it's at 6 months, it reduced for both groups, and this is neuroadaptation. So this is something that you have to tell patients that at 6 months, 3 to 6 months, it's much better. And overall patient satisfaction with Optiflex trio was 96%, AT LISA was 92%, similar. And to conclude, both trifocal IOLs provided excellent uncorrected visual acuity at all distances, no significant difference between visual acuity outcomes in both groups. Incidence of halos were similar, contrast sensitivity also was similar, spectacle independence, patient satisfaction also was similar, slightly better with Optiflex trio because we didn't have the PCO. But I think overall, most trifocal lenses perform quite well. You need to counsel the patients well. And today you have options for giving the patient uncorrected vision for all distances. You can tell them that 95% of the time, they don't have to depend on glasses. Don't promise them 100% because sometimes if they have a small refractive error or some of them may want to read very small print for which they may have to use glasses for specific tasks. Thank you very much for your attention. And if there are any questions. So I think we'll go on to the next speaker. And it is my pleasure to invite my dear friend, Dr. SPS Grewal from Chandigarh, who heads the Grewal Eye Institute. He's a senior surgeon who has a lot of experience with premium IOLs. He has a premium practice. And today he will be speaking on EDOF lenses, the balancing act. So for patients who are picky, who want better night vision, but they also want good distance, and they also want intermediate and also reading. So these are some patients where you'll have to probably look at EDOFs and see how they perform.
Thank you so much, Sri Ganesh, for the introduction. Nice seeing you after a long time. I'll be sharing the experiences with Symphony IOL. Am I audible clearly?
Yes, sir.
Yes, sir. You're
Okay. Now, the first thing is that today we'll be discussing why the EDOF lenses, what the Symphony promises to deliver, what is the technique behind these lenses, and how do you compare the results with the other IOLs? What is the patient counseling like and setting the expectations? Now, as Dr. Sri Ganesh has mentioned, that the intermediate vision has become increasingly sought after the constant increasing dependence on smartphone, tablets, and the computers. The bifocal and trifocal lenses provide sweet spots of vision and significant loss of contrast, and is robbing photic phenomenon. Now, the basic optical principle in a EDOF lens is that instead of having multiple foci like you have in a trifocal lens, the optics tend to elongate the focal point to enhance the depth of focus, on the contrary to the monofocal IOL, which will focus at 1 point, bifocal lenses at 2 points, or trifocal at 3 points. Now, the Technis Symphony has a biconvex wavefront designed anterior aspheric surface and a posterior achromatic diffractive surface with ashlets to extend depth of focus. An ideal design goal for a EDOF lens should address the following things. It should provide a full range of high quality spectacle independent vision. The incidence and halos and the glare should be comparable to a monofocal lens, and distance contrast vision should be comparable to, again, monofocal IOLs. To achieve this, the Symphony uses the Technis platform, the Ashler design, and the achromatic technology. The achromatic technology is aimed at reducing chromatic aberrations. Chromatic aberrations is when the white light is separated into its spectral components, and these wavelengths diffract differently, creating multiple focal points, leading to blur and reduction in the contrast sensitivity. The cornea is more powerful refracting blue light, and the implants are designed to reflect more the red light, so that the chromatic aberration from the lens and the cornea neutralize each other to make the eye as achromatic as possible, therefore enhancing the contrast. The other thing claimed with the Symphony is that due to an elongated depth of focus, it should be more forgiving in terms of a residual refractive error and possible centration, as Dr. Gaurav mentioned. So if you have a lens which is little forgiving at absorbing a little residual refraction, you are better off with patient satisfaction in these cases. How are the results with Symphony? If you plot the defocus curve of the Symphony, we see a relatively smooth shift from distance to intermediate vision, and then we see a dip when we come to the near vision. This graph shows the best corrected and uncorrected visual acuity at different distances, and we can clearly see the excellent intermediate vision, that broad, that line, horizontal line that you see achieved, but also again there is a sudden drop in the near vision. Now then, if we look at the cumulative spherical equivalent for the Technis Symphony, most of the cases they are ametropic, but then there is a good IOL constant optimization and a fairly predictable results that you achieve with this. At our practice, we adopt this simple 10-point questionnaire to determine the patient's satisfaction and quality of life. We administered this questionnaire to patients bilaterally implanted with Symphony, AT Lara, AT Lisa, both by Zeiss, and the Technis multifocal IOL. Basically, we got to compare most categories of presbyopic corrective lenses. When asked about the satisfaction with the distant vision, patients with Zeiss lenses appeared to be more satisfied compared to the Technis platform lenses, although the Symphony performed better than the bifocal lenses. So the extended depth of field lenses and trifocal both performed well, and both were better than the multifocal lenses. The question on satisfaction with near vision yielded some surprising results, with trifocal showing the clear advantage, but the EDOF lenses matching the bifocal lenses. This could be attributed to the smoother defocus curve of the Symphony, allowing patients to achieve a relatively more continuous range of vision and possibly compensate for the working distance a little bit. As expected, the Symphony outperformed the AT Lara and the multifocal Technis when it came to intermediate vision. However, the trifocal AT Lisa still performed better than even the Symphony. Again, the trifocal lens marginally outperformed the Technis lenses when it came to how comfortably the patient could adapt between photopic and mesopic visions. And when we looked at the ability to find the correct distance, the lenses were performing, the EDOF performed almost similar to the multifocal lenses. And patients at night reported relatively similar satisfaction with all the IOLs. Now, this point is very important because when we are counseling the patient, we should not be telling the patient that I'm using a particular lens because there are less chances of rings that you will see. Be very honest with the patient and make them ready and prepare them to handle the halos that they'll see. Do all of those cases see? No, it is seen in about, I'll put roughly around 30 to 40% of the cases. Some of them will tell that they can see only if you ask leading questions. Some of them, especially the type A personalities or the perfectionist and those people who are very expert at finding faults at things in life, they will be really annoyed. So if you can filter out these patients preoperatively, that will be good. Like I had a patient whose vision was 6.6. He had a little posterior capsular cataract, had a glare at night, and he was annoyed with the night driving, and he wanted to get a cataract surgery done. Now, if I put a multifocal in that lens, that patient is not going to be satisfied because his night vision will still have some issues. So as has been mentioned earlier, checking the personality, assessing the personality of the patient by more than one means is really important in these cases. Overall, patients with happier with the newer lenses compared to bifocals when it came to satisfaction level with the daytime. Now, the distant vision, daytime, if your biometry is accurate, is not an issue with any of the IOLs. The patient with Symphony and AT Lisa did report fewer difficulties in photic phenomena, definitely reflecting the improvement over the previous lenses. So the EDOF lens again demonstrated greater satisfaction when adapting the vision between different distances. And the Symphony IOL had good satisfaction again compared to the multifocal IOLs. Now, these are the defocus curve from these lenses. And as you can see, the near vision is good in the trifocal lenses. The intermediate lesion is better with the trifocal and EDOF lenses, and distant vision is almost comparable in all the lenses. So where do I prefer to use a Symphony IOL? Now that's a very difficult question to answer. I would have been very happy with if they were a complete range EDOF lenses. If I could get a lens which gives me a continuous focus without the humps that you get on the defocus curve, if it could make good continuous vision from distance to 30 centimeters, that would have been excellent. My main issue with the EDOF lenses has been the overall quality of vision for near. The near vision, and most of the people who are fond of reading and they want to be able to see clearly at 33 to 40 centimeter distance. And in that situation, the trifocals will give you more satisfied patients than the extended depth of field lenses. Monovision, micro monovision EDOF lenses again is something that can be worked up, but I'm still looking at implant as and when it is possible, which will give you a complete extended depth of field right from 33 centimeters to infinity without any photic phenomenon. Now, till then, we'll have to see which one works best in your hands. As Sri Ganesh went into great details to show the different parameters of the different lenses. It all depends which lens you started using, how comfortable you are with it. But one thing is there, as Dr. Sri Ganesh mentioned about the neuroadaptive mechanism. Any lens that you use, any kind of photic phenomena these patients are waiting, after 2 years, they'll be very comfortable. Now, the art is how to handle the patient in those 1 to 2 years' time. I had a surprise last month. I had a patient who had come for follow-up after almost 20 years. She had surgery done in one eye and the other eye was still phakic. And the first eye I had done array, and the patient had come after a very long follow-up. And I asked her, how are you doing? She said, I'm very good. My next question was, are you using glasses? She said, I'm not using glasses. Do you have any issues? She said, I don't have any issue. So those patients who have some issues with quality of vision in the immediate post-op period, they need to be handled very, very kind of, let me use the word expertly, without, you have to tell them everything very honestly to build up their confidence. And then you have to give them a very realistic time frame in which how the things are going to move. I don't think one need to rush through expanding the lens or doing anything or trying to convince the patient that you did a very good surgery, everything is fine. That statement should not be made. You should tell the patient that I agree with what you are saying. I understand what you are saying. I know what you are experiencing. And these things are going to settle over a period of time on its own. So have some patience. Thank you so much. And thank you, Dr. Ellen, for giving me this chance to be on this webinar.
Thank you, Dr. Grewal, for that excellent talk on EDOF lenses. We also have some new EDOF lenses coming, and the Vivity from Alcon is a new EDOF lens. And I have used a few of these lenses, and I find that it's quite good. Most patients don't have any dysphotopsia, and the night vision is fairly good when compared to the Symphony or other multifocal lenses. But and near vision also surprising after bilateral surgery. Some patients are able to read N6. Some people just read N8 or N10. So we'll have to see. I think we have to implant more of these lenses. Rayner also has introduced a new EDOF lens. So there's a new family of lenses, and now you have more lenses in your armamentarium. So you can decide what the patient wants, what is the lifestyle of the patient, whether they're actively driving at night, whether driving on the highway, whether their intermediate is more important or the near vision is more important. So I think assessing pre-op assessment and asking these questions to finally decide what type of lens you want to use is going to be very important for the final patient satisfaction. And of course, you have the biometry and the newer formulas and a thorough pre-op assessment, which is important. But I think we are in a position today to actually give spectacle free vision to most cataract patients and improve patient satisfaction. If there are any other comments or questions from the panelists or the audience, we can take them. Otherwise, we can end the session.
I just have one question from Grewal sir. Good evening, sir.
Yes. Yeah,
Excellent talk as always, really enjoyed. I just wanted to ask you, is your post-operative target for Symphony different from LARA?
Good question. No, for the first eye, no.
Okay.
Second eye, depending upon how the patient is, I may keep him 0.5 or minus 0.5 or minus 0.75.
Okay. Because I've seen that we've done studies with both lenses, and with AT LARA, somehow we see that we've actually given them we targeted emetropia. We didn't even do any micromonovision, but surprisingly, more than 90% patients read N5, even if you have a target of emetropia with LARA. But that's not the case with Symphony. With Symphony, certainly you have to do a 0.5 to 0.75 micromonovision.
At present, I'm restricted myself, or I'm using either the Eyhance lens for those who want to go in for monofocal, or I'm using trifocal, from Zeiss trifocal. So I'm just limiting myself to only 2 lenses. That's it. If somebody wants monofocal, I'll do the Eyhance, and if somebody wants for near and distance, then I'll do the Zeiss trifocal. Although 25, 30, 35% of the cases with Eyhance will be able to manage most of the things even without glasses. But then you can't promise it to the patient. You have to tell him that I'm doing a monofocal and intermediate vision you may be able to manage without glasses. Don't promise them near vision, but quite a good number of them will be able to manage for the near, not exactly N5 or something. And if I have to do monovision or a micromonovision so-called, then my preference will be Eyhance over a Symphony anytime, because then I can achieve the same objective with 0.75 in one eye and still have a greater depth, and then they take care of the photic phenomena and not worried about the glare.
So I think we have come to the end of the session, and I would like to thank my co-chair, Dr. Grewal, Dr. Ellen Kumaran, for inviting all of us to this session, and all the speakers for their excellent talks. Thank you very much, and I wish you all a good night.
Thanks a lot, sir. Despite the busy schedule, such busy practitioners, Dr. Grewal, sir, Dr. Gaurav, sir, Dr. Samaresh, Dr. Sheetal, Dr. Shreyas, and you were with me throughout, sir, Sri Ganesh. Thanks a lot, CrossCon.
Thank you. Thank you, Ellen.
Thank you, sir.
Thank
Thanks
you.
for the
Thank you.
opportunity.
Good night. Bye-bye.
Good night.
Bye-bye.
Bye-bye.